Hello, good evening, everyone. It's a great pleasure to welcome you all for this exciting webinar, Clinical Updates in Lung Cancer, Breast and Ovarian Cancer. This is done under the aegis of SOMEC Research and Health Organization, which is supported by Cancer Research and State Foundation. It's a pleasure to welcome the program convener, Dr. Jagdeep Singh, Assistant Professor, Medical Oncology at DMCH AOI, Ludhiana. So once again, a very warm welcome. Good evening to everyone. We hope to have a brilliant scientific discussions. Without wasting any more time, it's a pleasure to welcome the convener, Dr. Jagdeep Singh, for his welcome and introduction and taking the things forward. So good evening, Dr. Jagdeep, sir. Over to you for your remarks, please.
Good evening, Mr. Tarun. Thanks for all the gentle remarks. And good evening, Dr. Sunil. And
good evening.
Well to see you on time and really appreciate your this effort. So we have almost some 15, 16 people have already joined here. So I think we can start. So I welcome you all on this virtual meet, which is just organized in a short span and efforts put by Mr. Tarun in organizing with this. So thanks to that all team. And it is just, he has already told that it is under the aegis of SOMEX, which is supported by the Cancer Statics and Research. So we will be covering the things in the first day. We'll be covering on the lung, followed by the breast and the ovary. So our topic, first day lecture starts with Dr. Sunil Sricha. He's a well-renowned oncopathologist in the Jeev Gandhi Cancer Institute. So he will give us highlights on the biomarkers in lung cancer. So over to you, Dr. Sunil.
Thank you, Dr. Jagdeep, for the kind introduction. First of all, I would like to thank you and the organizing team for inviting me on this platform. And it's really a pleasure to be here with all of you. So can I share my screen?
Yes, sir.
So my slide is visible?
Yes, sir. Your slides are visible, sir.
So it's moving, right? So I can start now?
Yes.
So
yes,
I'll be talking about the predictive biomarkers in lung cancer. So tissue is always the issue. So the endoscopist and radiologist, they should be encouraged to perform multiple sampling. Ideally, 5 cores are good enough. Pathologists should manage these cores wisely and judiciously. So one has to economize on the use of the tissue. Each core of the tissue should be blocked separately. Initial diagnosis has to be completed using 4 sections, and one has to rely on morphology and limited immunohistochemistry. And why it is important to go for the upfront or reflex molecular testing for specified markers, because the appropriate number of the tissue sections, they are cut for the first time. And there is no repeated trimming of the block and wastage of the tissue. And moreover, the turnaround time is also controlled, which is very much required nowadays. So as we all know that 90% of the lung cancers are basically NSCLCs. And the role of the pathologist in this current era is not only just to diagnose a lung cancer, but also to find out the predictive biomarkers, to find out the biomarkers so that the patient can be put on the targeted therapy. And why it is important? Because this is the survival of the patient with drivers in lung cancer mutation consortium, when the patients were put on targeted versus no targeted therapy. So the consortium, they analyzed 733 patients for 10 genes, and they found the driver mutations in 64% of the cases, while 36% cases did not show any driver mutation identified. And one can see from this graph, there was a good prognostic separation of the curve when the patient were put on the targeted therapy. We can see this orange curve as compared to these blue and the black curves when the patient were not put on the targeted therapy or when there was no driver identified. Hence, the consortium demonstrates that the best outcomes are seen in the patients with identified drivers who are placed on targeted therapy with 3.5-year median survival, which is a very commendable thing for the oncology faculty. So although EGFR and ALK, they makes a bulk of the predictive, the biomarkers and the driver mutations, but there is a potential application even in the uncommon mutation which are beyond EGFR and ALK. For example, ROS, RET fusion, BRAF, MET splice, MET amplification, ERB2 amplification, ERB2 mutation. So in totality, they constitutes around 15% in all. And majority of these common and uncommon driver mutation are targetable with an FDA approved agent or on the clinical trial. Like the the drugs in the red font, these are on the clinical trials like mobocertinib, trastuzumab deruxtecan, and adagrasib. So in the last 1 decade, we have seen an unprecedented evolution of the therapy in lung cancer, and it's not a single disease, but many. And so is the biomarker testing in the lung cancer, which is a moving target. If you see the 2013 guidelines, the recommendation was to do EGFR and ALK gene fusion, and there was insufficient evidence to support NGS panel. In 2018 updated guidelines, besides EGFR and ALK, there was a recommendation for a ROS1 gene rearrangement and to add BRAF, B2, MET, RET if doing a large panel. And NGS panels were preferred over the single gene test if you are going beyond the first three. Moreover, the use of cell-free DNA, that is the plasma, that is the liquid biopsy for testing when the tissue was unavailable, and also the ESCO NCCN guidelines extended the recommendations to include the routine first-line BRAF mutation testing. So basically, in a nutshell, we have two broad categories. One is the minimum necessary, which is a must-do test, and the other is the recommended, that is should-do test. So these are the two categories which I'll be touching upon subsequently. So coming to the category of the must-do test, that is so first is the most important is the EGFR mutation, most robust predictive biomarkers for response to EGFR TKIs, and it confers a more favorable prognosis, and therefore a target therapy should be used ahead of chemotherapy and immunotherapy in EGFR positive NSCLC. Especially in the Asian population, lung adenocarcinoma, we have seen up to 60% of incidence, especially among the non-smokers females. Therefore, a great efforts has been made to standardize the diagnostic test, and approximately 90% of the EGFR mutations, they consist of either a deletion in exon 19 or a single point mutation L858R in exon 21. Two FDA-approved test kits are recommended, and we have both these platforms at our institute in our molecular labs. So one is the COBAS EGFR mutation test for the common activating mutation, and COBAS EGFR mutation test V2 for T790M mutation. The other is the QIAGEN TheraScreen. So these tests are highly sensitive and can detect the mutation in the samples with tumor infiltration as low as 10 to 20%. But unfortunately, the resistance to TKIs are inevitable. And these are the mechanism of the resistance post first-line EGFR TKIs. So these are the various mechanism, and the most common mechanism, as we all know, is the T790M that accounts for approximately 50% of the cases, and the drug of choice for this is the osimertinib. So here comes the role of liquid biopsy. Several studies that support the use of plasma genotyping as the first-line testing to detect T790M. The tissue biopsy would be required only when T790M is not detected in the plasma, as false negative rate of 30% is associated with plasma genotyping. However, the treatment response to either a tissue or a plasma detected sensitizing mutation is absolutely same. The recommended and established use of first-line osimertinib nowadays may largely prevent the development of the T790M resistance and has a better CNS penetration. Coming to the ALK rearrangement, so more than 12 different variants, EML ALK variants and non-EML fusion genes have been detected. The impact of these variants on the heterogeneity of the response to the ALK inhibitor has not been fully elucidated. So they are seen in 5 to 8% of the patients with advanced or metastatic NSCLC, commonly seen in young non-smokers. So these so the studies and especially the systemic review and meta-analysis have shown the superiority of ALK inhibitors over the chemotherapy in terms of PFS as well as in terms of objective response rate. And the next generation agents like alectinib and brigatinib yielded a better response intracranially than crizotinib in terms of objective response rate as well as from time to CNS progression. Regarding the methods of identification, if you are going by a single gene, so immunohistochemistry and FISH are the recommended, and NGS as a part of multi-gene assay. So in FISH, what happens is that we tag a one probe to the ALK region and one probe we tag just adjacent to the ALK region. So if there is a rearrangement, so the probes will be gone distant apart, and what is reflected in the sorry, in the FISH microscopy, we can see that if there is a rearrangement, we will have a break apart signals. Excuse me. So, but we are preferring immunohistochemistry as the first line of testing at our institute. We can see a positive test can have a strong diffuse immunoexpression, or even a moderate to strong intensity in a heterogeneous pattern is also a positive test. So basically, what are the advantages of the immunohistochemistry? It is faster, cheaper. We can go for this testing even in a 6 hours. The standardization is much easier. More labs can do it. It is reliable as the normal lung tissue do not express L. And this is the recommended clone D5F3 from Roche to be used on Ventana platform, which has been FDA approved as a companion diagnostic test for crizotinib. And we are using it for last many years. The superiority of the tyrosine kinase inhibitor crizotinib over chemotherapy in the first line ALK positive advanced NSCLC was proven long back in 2014. However, the resistance to treatment invariably develops, often with progression in the brain. So the second and the third generation TKIs have proven their better efficacy. And nowadays, the third generation lorlatinib, which led to a 72% improvement in PFS compared with the crizotinib in the first line treatment. The next important biomarker is ROS1. It is basically a receptor tyrosine kinase. It's an oncogene 1, and it's seen in the rearrangement is seen in 1 to 2% of NSCLC. It is because of the translocation between the ROS1 and the other genes. The most common is the CD74, which ultimately leads to the activation of the downstream oncogenic pathway leading to tumorigenesis. So this rearrangement actually is sensitive to the ROS1 inhibitor, that is crizotinib and entrectinib are FDA approved, who are treatment naive patients or post chemotherapy. Regarding the methods of detection, FISH is recommended as a single gene assay and NGS is recommended as a part of multi-gene assay. Immunohistochemistry is a very effective and a very a good way of screening, and we are using it at our institute for last many years. Like we are having this clone D4 D6 cell signaling antibody, which is a recommended antibody, and recently SP384 from Ventana is also an additional recommended antibody. But the bottom line is that all positive immunohistochemistry cases of ROS1 must be confirmed with the FISH analysis before starting on the targeted therapy. So unlike ALK, where an IC result positive in ALK positive cases, you straight away put the patient on ALK inhibitor, but for ROS1 immunohistochemistry positive cases, they have to be confirmed with FISH analysis. So this was just to highlight a case. This was a adenocarcinoma with some micropapillary pattern of growth, and that was ROS1 strong and diffuse expression, but it was confirmed on FISH, and then patient was put on the ROS1 inhibitor therapy and showed a very good response. So this is the fourth, that is the BRAF mutation. It's a downstream signaling mediator of KRAS that activates the MAP kinase pathway. The activating mutations are observed in 1 to 3% of NSCLC. Mutation can occur at V600 position of exon 15 or outside this domain. And the NSCLC patient who progressed on chemotherapy, the combination of BRAF and MEK inhibitor, that is dabrafenib and trametinib, has been approved by FDA. The preferred testing, again, if you're going for a single gene assay, PCR sequencing, and for a multi-gene assay, NGS. So these were the initial trials that showed encouraging results in which the dabrafenib plus trametinib could represent a new targeted therapy with robust anti-tumor activity and manageable safety profile in patients with previously treated or untreated BRAF V600E mutant NSCLC. So now coming to the recommended or should do test. So most important is the MET exon 14 skipping mutation and amplification, because that leads to the dysregulation of the MET pathway. So just very briefly, what is the MET pathway? The MET is a proto-oncogene, basically that encodes the tyrosine kinase receptor for hepatocyte growth factor, which is a ligand. So when there is a abnormal splicing, so that leads to the exon 14 skipping, as we can see in the messenger RNA, the exon 14 is skipped. So that basically what it leads to a truncated protein part of the juxtamembrane domain, the Y1003 protein. So basically this is important for binding to CLB, which is required for ubiquitination degradation pathway. So what happens if when this protein is truncated, so what happens, the receptor will not be degraded. So there will be a constitutive activation of the MET pathway that will lead to tumorigenesis. So when to anticipate these type of mutations? So if you have on morphology, you have a sarcomatoid pattern of growth. So if you have a carcinosarcomatous or a sarcomatoid carcinoma, so approximately it has seen that 20 to 30% of these tumors show MET exon skipping mutation. So this morphological pattern, if pathologists get encountered, so he may warrant upfront MET gene testing. So what are the characteristics of this MET exon 14 skipping mutation? So they are seen in 3 to 4% of all the metastatic NSCLC, can be associated with MET amplification, copy number variants. commonly seen in females, elderly, and non-smokers, and highly predictive of response to MET inhibitors. The FDA has approved the two drugs capmatinib and tepotinib. Besides the predictive utility, the MET exon 14 skipping mutation is an independent indicator of a poor prognosis for a shorter overall survival in NSCLC patient. As evident from these graphs, there is a prognostic separation of the curves when so this MET exon 14 we can see associated with the poor prognosis. So FDA has approved the Foundation One companion diagnostic to aid in the detection of MET exon 14 in tumor tissue. But recently, the RNA-based sequencing is now much more preferred and over the DNA-based NGS, as the RNA sequencing has the advantage of encompassing all the causal genomic events that lead to exon 14 skipping, hence being much more sensitive. And RNA sequencing detects the fusion of exon 13 to 15. So we are dealing with the end result. And in one study, approximately 60% of the RNA positive results, they were found to be false negative in DNA analysis assays. And that was published in JTO. So just a very simple diagrammatic explanation. So what happens is that if there is a normal messenger RNA where exon 14 is intact, so we can see these are n number of base pairs. So what happens if there is a 14 is skipped, like exon 14 is absent over here. Now this exon 14 is having a 140 base pair. So what happens is that on sequencing, the number of base pair will be n minus 140. So coming to the MET amplification, also as a mechanism of MET dysregulation, the MET amplification is regarded as a primary driver gene and also one of the main mechanism of EGFR TKI resistance. Depending upon the assay and positivity cut point used, the occurrence of de novo MET amplification is about 1 to 6% in lung cancer in the various studies. And many studies have associated MET amplification with shorter overall survival. However, the high amplification, that is when the MET to the CEP7 ratio of more than 5, that appears to be the strongest predictor of true MET amplified driven tumor, which is seen in 0.34% of lung adenocarcinoma. Now, MET is also a co-driver in NSCLC. MET amplification in EGFR mutant NSCLC comprises of 5 to 15% of the EGFR mutated tumors that have acquired resistance to TKI. The liquid biopsy might be a very important tool to use in this situation to detect the secondary mutations without repeat biopsy and discomfort to the patient. And now with osimertinib as a first line of choice, the spectrum and association of MET mutation will remain to be seen in near future. Coming to the HER2 mutation, so HER2.
Dr. Sunil sir, excellent presentation and always last 2 minutes to conclude, sir.
Okay. So this is the HER2 mutations. So these are basically in-frame insertion in exon 20 and the early phase clinical trials suggest that the patient with tumors harboring HER2 mutation who progressed on chemotherapy may respond to trastuzumab-based regime. Regarding RET rearrangement, they are seen in 1 to 2%. They are seen in young never smokers. Again, NGS is the preferred modality, and FDA has approved sulpersatinib and pralsetinib for the metastatic RET fusion positive NSCLC. And encouraging results have been seen in the open label phase 1-2 Libretto 1001 study. Anti-RK fusion, the prevalence is seen in up to 1%. Larotrectinib and trectinib are 2 FDA approved. Again, NGS is recommended. Although IHC can be used, we are having this clone EPR 17341 for screening, but it is only for screening. It has to be confirmed on NGS or FISH. The drug larotrectinib has been approved and has shown a good response to the treatment. These I can skip, very rare. So yes, RAS mutation activating KRAS mutation, which activate a number of downstream signaling pathway. They are observed in approximately 25% of lung adenocarcinoma. NGS is a recommended. Multiple agents specifically targeting the KRAS G12C mutation have emerged. Sotorasib is approved by FDA for KRAS G12C mutated locally advanced or metastatic NSCLC who have received 1 or prior systemic therapy. So NGS is preferred over a single gene assay nowadays because it is tissue proficient. 10 nanogram input of DNA and RNA is sufficient. It is also resource proficient. 1 platform, 1 experiment. The variant allele detection cutoff is around 5%. Hence, it overcomes the problem of low tumor fraction. You can detect tier 1, tier 2, and tier 3 alterations so that the patient can be put on subsequently targeted therapy or they can be recruited in the clinical trials. And NGS can use plasma as a sample also. FDA's approval is there for analytical, clinical validity, and also the clinical utility. However, TAT is definitely a problem. So biomarkers, lastly, the biomarkers of immunotherapy. No robust biomarker. PD-L1 has emerged with some passable utility. So indications are in both in the first and second line. The pembrolizumab has been incorporated by the NCCN 3 years down the line. So these are the standard recommendation for the pembrolizumab. For the first line, if TPS is more than 50%, we can go for a monotherapy. When TPS is between 1 to 49%, has to be used in the chemotherapy in combination. For second line, for pembrolizumab, TPS has to be more than 1%. However, for nivolumab, for the first line, it has to be given in the combination of nivolumab plus ipilimumab when the TPS is more than 1%. However, for the second line, no PDL testing is required. Any TPS will do. So these are the two assays. We are all familiarized. So PDL-IC testing is an established biomarker for immune checkpoint inhibitor in NSCLC. It's not a very robust biomarker, but still the best we have. So to conclude, there is extensive role of biomarker testing in metastatic advanced NSCLC adenocarcinoma. The broad molecular testing, NGS and liquid biopsy have already made their place for biomarker assays. Multidisciplinary communication is essential for the quality information within required time frame, and that too at a judicious cost. And it's incumbent upon pathologists to make the testing reliable by optimizing pre-analytical, analytical, and post-analytical steps. Thank you. I'm happy to take any questions.
Thank you, Dr. Sunil. Wonderful and precise talk. And now it's a era of immunotherapy nowadays. Just one question to you. So, like, why you have this? Am I audible?
Yeah.
So, like, now we have this testing for PDL1 test 22C or SP140C or 263. So, can we use this interchangeably?
No. They are actually, as far as interchangeability is concerned regarding tumor proportion score. For lung cancer, we are using tumor proportion score. So the blueprint study has shown that SP263 and 22C3 Pharma DX, they have shown concordance. So they can still be interchangeable. And moreover, the SP263, although it has not got a FDA approval, it is CE marked, CE, that is European conformity marked. So that can be used, and we are using it at RGCA. But the third clone that you have mentioned is SP142. So that can never be used for lung cancer because this clone has a utility for staining the immune cells. So that is utilized for triple negative breast cancer when the patient has to be.
The thing why I'm asking, sometimes we are having some hindrance in getting the 22C3 PDL1 testing by the 22C3. So, and it is not available in all of the cities where we are practicing here. It's a majority times it is available in the metros or in the large cities. So that's why we face this problem in getting testing, this PDL1 testing. So,
right. So basically, if you don't have a accessible, if you don't have a 22C3 accessibility, you can still go for SP263, but not for SP142. That is only for the immune cell scoring.
So other thing that this is the 22C3 is the only companion diagnostic testing still approved. So yes. the other even 142, SP142 or 263 is also not the companion diagnostic test. So can we say that if it is not a companion diagnostic test, we should not offer that to the patient?
No. SP263 is also a companion diagnostic that you have to utilize the specified platform, the same antibody clone, the same specifications. Okay. Like in my PPT, I have shown the last slide. Actually, I have to take it hurriedly because the time was short. So the Ventana platform SP263, that is a companion diagnostic test.
Okay.
So the thing is that you cannot use this antibody on another platform. Like suppose if your lab is having a Leica bond, another platform. So you cannot use this Ventana clone of SP263 on Leica bond platform. So a particular clone has to be used on the particular platform, and that too with the particular reagents of that company. So that makes it a companion diagnostic. Okay.
So anybody else who has a question for Dr. Sunil?
We are short of time, so you need to invite the next speaker. So I mean the questions are brilliant if it can be done on the chat box.
Okay. Thank you, Dr. Sunil. Thank you for a wonderful lecture. And
thank you, Dr.
It has given a lot of insight. Thank you, sir.
Thank you. My pleasure.
My next speaker is Dr. Ashwin Phillips. Ashwin, are you there?
Yeah, Jagdeep, I'm here. Don't worry. I'm here.
Okay, thank you. So Dr. Ashwin Phillips, he's a medical oncologist at CMC Ludhiana. He's associate professor and head of department. And we usually meet each other in some or the CMEs. So nice to have you here. So he's going to give next session on decoding the treatment in EGFR positive lung cancer.
Can the host allow me to share the screen? Yeah. Thank you, Jagdeep. Thank you for this introduction and thanks for inviting me. It's always a pleasure to discuss. We were also in a meeting yesterday, so a lot of enlightenment was there yesterday as well. So without wasting much time, I want to talk about how do you decode the treatment of EGFR mutated non-small cell lung cancer. But what is important is the fact that we all know that lung cancer is there to stay, and worldwide, if you look at both male and female, this is one of the second most common cancers you would see. Even in India, the Chennai registry would tell you that that is one of the most common things you would see in the Chennai registry as well. Now, what is important is that even though it is second most, it's one of the leading causes of death. And technically, the problem is we even though we are having more options nowadays, it's about sequencing and how we best sequence and do we use our best weapon upfront. So when you treat somebody with a lung cancer, you're looking at a few things. One is the PFS. How do you sequence it? You base your treatment based on your PFS, overall survival, objective response rates. The presence of brain metastasis is a very important thing because a lot of our treatment may today depend upon the presence or absence of brain mets. Definitely the safety, the toxicity, the quality of our life. And one thing, because we are having multiple options and we have good options coming up upfront, is that we need to see how do we sequence. And if we use the best weapon upfront, what do we have later on? These are things that we're going to discuss in today's talk. Now, we all know from the time of the IPAS, which revolutionized the way we looked at lung cancer. Till then, I think everybody was giving chemotherapy irrespective. But the first time you understood that a targeted therapy could have been effective was the use of gefitinib, which most of the first line gave you a PFS of around 9 to 12 months. And your IPAS optimally looked at gefitinib and erlotinib, even though they did not show an overall survival because the studies had a crossover in them. Then you have the second generation of EGFR anti-TKIs coming, afatinib and dacomatinib. And the Archer study definitely showing you survival advantage compared to your standard of your gefitinib. Now, where does your osimertinib come is that your FLORA study definitely showed that a PFS is much better than your standard of care at that point of time. FLORA comes from after the AURA study, in which they had given patients who had progressed after the first line therapy with the EGFR anti-EGFR therapy. They had compared it with pemetrexed versus the patients with a T790 mutation. But this the FLORA study did not look at those patients. Look at everybody who had upfront treatment, and that is how you base your treatment. So if you look at all the studies, like we discussed, we're talking about the second line, second generation TKIs, the Lux Lung 7, the Archer, and the FLORA. In most of these things, what you would see is that the curves separate quite late. In the Archer, at least it's after 6 months. Whereas in the FLORA, the curves separate right at the beginning, showing that how efficacious the drug was supposed to be. And in FLORA, you already had patients who had brain metastasis, who were not treated, but stable brain metastasis. So this is one of the important things that you will understand. Irrespective of the T790 mutation, this drug was going to be much, much more effective. Now, if you look at the objective response rate, which is another thing that we look in most of these patients, and you will understand that compared to both your second generation TKIs, your objective response rate with the osimertinib was as high as 80%. And the important thing is the duration of response. You would get a median duration of response of around 14 months with your dacomatinib, whereas your response is around 18 months, 17.2 months or 18 months with your osimertinib. So the duration of responses were also were higher with your first line, the third generation TKI. So that is one of the reasons. And if you look at the overall survival, what you would see is that osimertinib versus a comparator TKI was around 38.6 months versus 31 months, and the median overall survival is more than 3 years. What is important is if you look at the mid marks of 2 years and 36 months, these are the areas where the curves are much more separated. And this is the first time that, one of the important things of the FLORA study was the fact that this is the first of the studies which showed a survival advantage as compared to the other drugs that you had usually used. Now, if you look at it, Archer, even though the curves are well separated, the thing with Archer was that when they planned the analysis, they had done a hypothesis, they had done a hierarchical procedure of doing the analysis. So if the PFS was more than the objective response rate, and if that was small, then you would look at the OS. So because that was because the objective response rate was not statistically significant, hence they have not done a formal testing of your overall survival. Now, so this is what we discussed right before, that the fact that the Archer did not formally test the objective the overall survival. And the important thing is, if you look at this 3 years survival, you would see that majority, at least 28% of the patients compared to the other standard of care would be on your osimertinib, which is showing you that almost 3 times more patients would be alive and on treatment with your TKI or the third generation TKI. Now, this is important thing. When they did the Aura study, they had actually kept a secondary objective of looking at patients with CNS metastasis as well. So we knew that this drug was going to be effective on patients with CNS metastasis. And what we see in the FLORA is that patients with known treated metastasis, there the median PFS is around 15.2 versus your standard of care of 9.6. Those who had who did not have treatment, they had 19.6 versus 10.9 months. So this is also an important fact that the drug was very effective. It prevented, it reduced the chances of CNS metastasis as well as controlled these patients with CNS metastasis as well. So if you look at the intracranial response, again, if you look at it for those patients who had a disease, you would understand that the median PFS is not reached versus 13.9 months. So this is showing you the fact that those patients, the drug was highly efficacious and much better for those who have CNS metastasis or to prevent a CNS disease. Now, if you look at the response rate, CNS responses, you'll understand that compared to most of these things, even though there is some data on Archer, even though that's not formally tested, that you could consider using it, but it is not a formal testing. If at all your patient had asymptomatic CNS metastasis or patients were treated by disease, osimertinib would be a much better option, because most of the other studies would have excluded these class of subset of patients as well. One of the biggest things that you would notice as you treat these patients with the TKI is the toxicities. And if you've used the Archer protocol, and you will understand the fact that the toxicities were quite high. You would dacomatinib would give you quite significant toxicities like diarrhea, the rashes, which definitely will lead to dose reduction. If you use afatinib also, the incidence of these side effects are quite higher. Whereas if you look at osimertinib, the fact that it's a third generation probably, and the fact that it didn't have much side effects. If you look at the grade 3 or more side effects, adverse events, they're only 18% of the patients. And compared to the setting, you would worry more about like diarrhea or fatigue. They were actually better than the other comparators. So the things that we worry about are the skin lesions that you see most of the time, the diarrhea, which can be problematic for most of the patients. Afatinib, the issue of the diarrhea, the skin lesions, and dacomatinib, most of the time I've used that to reduce the dose. So one of the advantages of osimertinib was the fact that these incidents were much lower, and hence the patient compliance would have been better. So again, this is what we discussed. If you look at the toxicities, you will understand that afatinib has a set of issues. Again, Archer study, dacomatinib also has. But if you look at osimertinib, the dose reduction was similar between a standard TKI versus osimertinib, showing that the drug's side effect profile was much better, and the tolerance hence would have been much better. Look at the quality of life. Again, you see that especially if you have a better side effect profile, definitely the quality of life definitely is going to be better, and that is what you see here as well. Now, this is what we always discuss about how do we sequence and why should we sequence, and the fact that only 1/3 of these patients who probably would take a first generation TKI would go on to receive a second generation. The biggest problem is not just that, is the fact that when you have a person on disease progression, to do a repeat biopsy, either a liquid biopsy or a tissue biopsy, wait for the result and then start. Which again, there is not much of data of giving osimertinib in those patients who don't have a T790 mutation on biopsy. So the fact that there will be, if you look at 50% of patients having a T790 mutation, what about the other 50%? So that is also one way of looking at it, saying that if you use a drug upfront, probably it will cover for everything. So provided they can afford it. So that is one way of looking at it. If you would afford, there's no question asked that this could be the best option to do it, take it forward. So this is what we look. This is again related to second line therapy, which shows that most of these patients, approximately 1/3 of the patients, don't have access to second line therapy or don't go on to it. Another thing to understand is when your patient develops EGFR resistance in EGFR, you have to look at other mechanisms like the HER2 amplification or any of the other things that are going to come up in these patients as well. So if you look at today nowadays we are talking about a lot of real world data. We are trying to see what you see in clinical trials. Does it really translate? Because a real world patient is slightly more different from a clinical trial patient who has a very good performance status, who are highly selected patients for a trial. So you have this Japanese and this Taiwanese data which looked at patients who had disease progression after afatinib and who had a T790 mutation. You would see that almost 43% or 48% of these patients would have a T790 mutations. So which is what you would see. But my question that I ask most of the time is, what about the other 50%? So they, if you can afford, is one thing you have to look at. So if you go to sequencing, it is a bit difficult because the main thing that I find is convincing a patient for a repeat biopsy, especially for the lung or through mediastinoscopy or through an EBUS. It is difficult. It's okay if they have a peripheral lesion. Liquid biopsy definitely is an option. So considerable time it is spent, especially if you're not in a government setup or if you're not in a major city like Delhi or Bombay. You would end up spending considerable time convincing the patients. And again, getting a biopsy may not always, lung biopsy is always tricky. We may end up getting an empty biopsy as well. Now, one of the things that if you have major toxicities to your TKIs is that we recently had a patient who we could not even put on the second, go on to the third line because of the fact the toxicities, and the patient was so upset of the toxicities, they were very hesitant to go on to other sites to continue next set of treatment as well. So if you look at the first line data of patients on the real world setting, you do have a lot of data. A bit of them is one is Italian data for the flower study, which shows you that even in the real world, the time to disease progression is around 25.3 months. And it is as effective as what you see the trial. If the median PFS is around 18.9 months, which is almost similar to what they got on the trial as well. And this is an important thing. There is also other data which looked at patients, and this is a prospective single arm observational study, and then they looked at all the things, the time from biopsy to pathology report and all these things. And what they found is that if looking at the toxicity, embolism was a common toxicity around 7.9%. Other than that, the efficacy was equally important. Yes, in the real world setting, they did find that there was diarrhea and skin rashes as well. So if you look at it from that point of view, but if you look at it from the overall survival, the PFS benefit, it shows that osimertinib almost touched the real world data almost reflects what you see in the clinical trials as well. So this is also another study which looked at these subset of patients. It was a retrospective Japanese study. It's like a multi-center. And again, they had substantial amount of patients on the study. And the most common mutation, as you expect, is exon 19 or exon 21. Again, showing you that the median treatment time to failure is around 19.9 months. And the PFS, median PFS is around 20.5 months. Again, very significant, almost as similar as what you would see in the study as well. Now, toxicities, if you look at it, yes, what you're looking about is all grades of toxicities around 12.8% in the real world setting. The most of the toxicities will happen within the first 2 months. And the most common toxicity that you would see in the real world would be would be pneumonitis. And another thing that most common reason of stopping the disease, the therapy would be disease progression. So this is one toxicity that was seen in the real world setting that is not very obvious in the flower trial as well. So another data which looks at it again is another real world data. Again, like we said before, it's almost similar. So in this patients, what happened is that at least 18% of these patients had to sit for the second line treatments. And if you look at the treatment time to disease, it was around 17.2 months. So all these data, the real world data, which is what is important at the end of the day, is what we practice and what we see. These patients, there also it's extremely important to look at the data. Yeah. So as we come to the end, the NCCN clearly says that if you have to use a TKI, if you can afford, I would say definitely osimertinib would be the standard of care, irrespective of your mutation is, because I think using the best weapon upfront would give you the best results, especially no doubts asked if the patient has brain metastasis at this point of time. So this is what we yesterday had also discussed, that if you could have bring in osimertinib upfront, there's no questions asked, the evidence is much stronger. If not, then you had to consider using gefitinib with your doublet chemotherapy, dacomatinib monotherapy, and sequencing it from there on. So like I would like to conclude by saying that, yeah, osimertinib is the only TKI that has shown a survival advantage and statistically significant. And the fact that you're almost 3 times patients were on the drug at the end of 3 years is important. Irrespective of your T790 mutation status, this will be the drug of choice that the patient can afford. If your patient has CNS mets, then I don't think there are much questions asked. If you could afford, there's no questions asked about this. Sequencing is an option, but the thing is that only 50% of these patients would end up getting those sort of will be beneficial. So my look at this is that what about the other 50%? So the use of osimertinib, if the patient can afford, will be the main thing to be looked upon in this type of treatment. Thank you.
Thank you, Dr. Ashwin. It was again.
So for the next speaker, Dr. Rajeshwar Singh sir is joining in a minute.
Okay.
So maybe you can have 1 or 2 questions.
Okay. So, hello, Ashwin. Are you able to, yes. So, like, how many samples in your practice you send for the liquid biopsy if you are handing a patient having you feel that resistance is there and the tissue is not available?
Yeah, Jagdeep, to be very frank, I'm heavily relying on liquid biopsy because the second time to get somebody to a lung biopsy, he showed to run. So I use the coupon and I send it for liquid biopsy because convincing somebody to do a lung biopsy, again, CT guided, very difficult. Bronchoscopy may be a bit more easier. So most of the time, up till now, at least 10 patients is what I've used the liquid biopsy for.
So what was the result you have found in that?
See, only 3 of my patients had a T790 mutation. So that is what I'm worried about. These patients, what about the rest? Even though we say it's as high as 50%, but again, my numbers are small, so I really can't comment too much on it.
So we have a lot of data on osimertinib from the phase 3 data and from the real world data from the different countries. Of course, this is a drug of choice if given, but the financial constraint is one of the biggest problems. Yes. So I can see Dr. Kunal sir, if you can, if any question or anything you want to discuss with Ashwin.
No, I think the biggest challenge is obviously the finances. So just to know, among the patients with the EGFR mutation, what percentage end up getting osimertinib as first line, or even if you find out T790M, what percentage of those, like 3 patients, were they all affording for osimertinib, and what is the first line?
So, you know, I work in a center where I can use these molecules because I have the ECHS ESI backup. So those patients whom I tested only if they could afford to go on to this. Upfront is when I used it for 4 patients, but 2 of them had CNS metastasis upfront. So I didn't even discuss further on these patients. On those 3 patients who had, only 1 of them went on to take osimertinib, but they were lost to follow up for some time. But the other patients went on to take it for some.
So Dr. Jagdeep, we have Brigadier Rajeshwar sir with us, and he's absolutely ready. If you can introduce and take the distinction.
Thank you, Ashwin. Thank you. Good evening, Dr. Rajeshwar. Good evening, sir.
Good evening.
So we have Dr. Rajesh Singh with us. He is a well-renowned medical oncologist. He is senior person among us. And sir is presently director of medical oncology at Paris Hospital. Sir, welcome to you, sir. So can we have the lecture from yours? Sir is going to deliver a lecture on management of first line ALK-related non-small cell lung cancer. Over to you, sir.
Thank you, Dr. Jagdeep. Okay, I'll be going a little faster. Basically, my disclaimer is that this is no financial issues will be discussed in this, because obviously this is not for people who have no financial resources, and India is improving and many people are coming whose finances are very assured, and at our age is importance is that symptoms should not be there. Money doesn't matter. So lung cancer, as we know, that it is a bad disease, high mortality rate, or if you want to have any type of lung disease, it should be ALK mutation, because such a good responses and such a prolonged responses we have. So ALK gene is seen in roughly 4% of the people, and typically adenocarcinoma histology, non-smoker, light smoker, and tend to occur in a younger patient. And we have good diagnostic now, both ISC, FISH, as well as NGS, and AML, ALK gene arrangement is seen in this. So there was a requirement of a drug which could be has got a good CNS penetration, and I think lorlatinib is a drug which bind in high affinity to most ALK resistant mutation and very good CNS. So basic problem in ALK is that OS is very, very long in all the first generation, second generation, third. But the problem is CNS metastasis, which occur in 20 to 40%. And getting a CNS metastasis is very devastating for a patient who has taken medicine for so long. Thereafter, the quality of life goes very down once the CNS metastases are there, and we have to treat with radiotherapy or other. So how do we manage this CNS disease? Of course, if patient is not symptomatic, and we can give targeted therapy like ALK TKIs or chemotherapy. And if patient is symptomatic, larger lesion, then either a surgical resection or whole brain radiation, depending on SBRT is also there. So basically, what we want is that, because this is the most important thing, any drug which is very good CNS penetration is the drug we should be given in this. So what are the guidelines for the CNS metastasis? All the drugs can be given, even ceritinib can be given, or in some circumstances, crizotinib. So how do we decide that which drug is better than in CNS penetration of all the 4 drugs which are available with us? And if we see that of all this, if we give first line lorlatinib, it gives a maximum PFS, and other second generation ALK TKI, they give PFS longer, but then they develop mutations which are present, and then we have to come back to. It's a similar situation what we heard from Dr. Philip regarding, you see, giving osimertinib whether in a first line or a second line setting. So we can detect metastasis, and we can do ctDNA and CSF, which can, if we want to if we want to find the diagnosis and type of mutation in this. So why lorlatinib? Phase 2 trials have shown that after the you see progression on other TKIs, this drug was very effective in managing and preventing of. It is also effective in managing and preventing the emergence of brain metastasis. So in untreated patient also, it eliminates rare pre-existing clones harboring ALK resistant mutation or delay the emergence of such subclones. So this phase 3 CROWN trial was done to study. This is basically eligible criteria is stage 4 non-small cell PS 0 to 1. Now they had included asymptomatic or untreated CNS metastasis, also more than one extracranial measurable target lesion. And they were stratified in form of brain metastasis, yes or no, or ethnicity, whether Asian or non-Asian. And the primary endpoint was PFS by blinded independent center review. And secondary endpoint was PFS, ORR, and other. We'll come to that. Now, if you see the baseline character, all these were well matched, both in lorlatinib and crizotinib arms. So it was comparator was crizotinib, and whether sex, race, Asian, non-Asian, PS, smoking history, stage of disease, adenocarcinoma, of course, was a 90%, and brain metastasis. We see both 26 and 27 patients were there. So 18 months follow-up, first interim analysis was there, and if we see the primary endpoint by BICR, it was not reached. It was not reached. Whereas in case of crizotinib, it was 9.3 months with a hazard of 0.028. Such good hazards are rarely seen. And if you see that subgroup analysis, in fact, all the groups were were benefiting. Asian, those little less, but numbers were less, so we cannot take any conclusion from this. And if you see by ORR by BICR, ORR in patient with brain metastasis at brain at baseline, this is all body, Here the PR were more and CR were less, but still very higher in case of lorlatinib as compared to crizotinib. But if you see the intracranial ORR, here the differences you see. It is 66% as compared to 20%, but you see the CRs were, majority of them was CR and very few PR in this. So very good drug, and duration of response also had not reached. And even intracranial patient with measurable brain metastasis at baseline, it was very, very high responses in this. Now, time to CNS progression, if we see, look at the upper curve. It is almost 90%. Only one patient had died. And you compare with crizotinib, its hazard is 0.07. I don't know whether we see such hazard anywhere else in cancer. Such lovely hazards I have not seen in any of the trials. Similarly, if we see the cumulative incidence of CNS and non-CNS progression in the first event, incidence CNS progression, only one patient progressed at 12 months, whereas in crizotinib it is 33%, that is 2.8 and 33%. Whereas cumulative incidence of non-CNS progression is also very high in lorlatinib as compared to crizotinib. Overall survival, because all these drugs, even crizotinib, survival is more than 4 years if we see. So though it is not reached in both the drug, but hazard is crossing, the confidence interval is crossing 1.25, but it's still very high. And maybe it's a very early data. The difference is required will come after some years. Quality of life, we see the quality of life as compared to crizotinib was very, very high as in lorlatinib. I should not go into minor detail of this. All subgroup, the quality of life scores were much higher in lorlatinib as compared to this. Even 36-month follow-up, if you see the 63% as compared to 18.9% the PFS with a hazard of 0.27. Very, very significant. And it is again at 36 months also all the subgroup are benefiting from lorlatinib as compared to the crizotinib. And if you see PFS in patient without brain metastasis, patient with brain metastasis, again it has not reached the median has not reached, whereas the curve of crizotinib is going very down. And without brain metastasis also lorlatinib is doing very well as compared to crizotinib with a hazard of 0.29. So intracranial time to progression with baseline brain metastasis. Patient who had brain metastasis, how they, after giving this treatment, how did they progress? It took how much time? If you see the, it is 73%. It has not reached, the median PFS is not reached as compared to crizotinib. Again, in intracranial disease, getting 0.10 hazard, very rare to see in any drug. Similarly, intracranial time to progression without brain metastasis, there was no, only probably 99% they are saying was there at about 48 months also, 36 months they evaluated, but it's still, and it has almost touched the 15% in case of crizotinib with a hazard of 0.02. So in all subgroup, if you see intent to treat population, patient with brain metastasis at baseline or had one measurable brain metastasis at baseline, no need to go in data. I mean, the story is in front of you. It is lovely responses with this. And as far as toxicity is concerned, discontinuation was seen in 7.4%. There is hardly any difference between crizotinib and so mainly the adverse events were hypercholesteremia, triglyceridemia, edema, weight gain, and rest were the usual of our TKI complication, which are present in all TKI, whether it is crizotinib or other TKI. Main was the lipid derangement and edema, which is easily manageable. So 18 months additional follow-up in this shows that the 3-year rate was 63% in lorlatinib as compared to 18.1 in crizotinib. Similarly, only one of the 112 patients shows the evidence of intracranial progression, suggesting a protective effect against the development of brain metastasis in lorlatinib. So no new safety signal were observed in longer follow-up. Now, these are the first-line recommendation: alectinib, brigatinib, lorlatinib, and of course, all the drugs can be given in first line. But how do we decide which one there? And network meta-analysis were recently presented in 21 World Conference on Lung Cancer, and they have gone to all the trial. The LX, the JLX, where the 300 and 600 was done in LX and JLX 300 milligram.
So you have just 5 minutes to conclude.
Okay, 5 minutes is enough. So this shows that as far as PFS is concerned, nobody is nearer to lorlatinib. All are favoring lorlatinib. As far as overall survival is concerned, overall survival is immature at this moment, but whatever evidence we have, except for alectinib using very high dose in the Alex trial, all are favoring lorlatinib. As far as toxicity is concerned, I think alectinib takes the cake on this. Similarly, another comparison was done of the three lorlatinib, alectinib, and brigatinib. Now, I must tell you, this is not head exam evaluation. These are all meta-analysis which has been done. And this also indicates that lorlatinib is better than all the three of them. And in subgroup analysis, again, some Asian were having a favor as compared to towards alectinib. But if you leave out that, though the number you can say are lesser, but I will not say they were favoring alectinib. But apart from that, whether it is alectinib or brigatinib, lorlatinib takes the cake on this. So this meta-analysis concludes that whatever is written, but what I read about is this. Basically, if you want to see the PFS, nothing to beat lorlatinib. Overall survival, little bit alectinib is there. Toxicity, a little bit alectinib is better than lorlatinib and other drugs. And but as far as CNS disease control is there, the best is that lorlatinib. So resistant pattern, we see that different resistance in crizotinib, ceritinib, and alectinib we see. But if we see that lorlatinib overcomes all this resistance, but only if it is used early. Giving in second line or third line, effect is not there. As you go the second line and third line, the effect of lorlatinib is very, very less in this, because there is a development of monster mutations slowly and steadily. So it is better if you give, this is the same, just like in EGFR mutated with osimertinib, we have the PFS, the best PFS is by lorlatinib. If you want to increase the patient survival as well as CNS, which is the most important toxic, the debilitating thing in a case of CL lung, that is prevented by lorlatinib as compared to, or whether you can give first, second, third line. Second line in lorlatinib is also recommended, but you see the PFS doesn't go beyond 6 to 7 months thereafter. But if you give after alectinib, maybe slightly there, but both the drugs are equally expensive. So no point in going to alectinib. Better is if tolerance is an issue, toxicity is not there, lorlatinib takes the cake. So in treatment of naive ALK non-small cell cancer, compared to crizotinib first line, the lorlatinib has a longer PFS, higher overall and intracranial responses, and global quality of life. Safety profile is also manageable. So grade 3 and 4 adverse events are not very large as compared to this. So if we try the sequence, 35% of patients with develop compound ALK resistant mutation, even onto lorlatinib. So it is better that lorlatinib is given in the first line with advanced ALK non-small cell lung cancer. Thank you. I hope I kept my time.
Thank you, sir. So it was a precise talk on the lorlatinib. The issue is always with the intracranial metastasis, either at the upfront or maybe at the progression, and both in either EGFR or in the ALK positive patient. So we have now drugs, osimertinib and lorlatinib, the patient, they can have a better outcome. So anybody else want to add or ask something from sir? So I think we can go to the next session. Thank you, sir. Thank you so much.
Thank you very much, Dr.
For your
Vijay.
valuable time, sir.
Thank you very much for giving the opportunity.
Thank you, sir. So next talk is by Dr. Devinder Pal, my fellow colleague. Initially, we were in UI Ludhiana. So now Dr. Devinder Pal is a Director of Medical Oncology at Fortis Hospital, Ludhiana. Dr. Devinder, are you there?
Yeah, good evening, Dr. Jaydeep. Am I audible?
Yes, you are. Nice to see you.
So good. It's pleasure is both ways. So good evening, everybody. So thanks, Dr. Jagdeep and the sponsor for giving me this opportunity for having my talk in this update. So I'll be discussing about the personalized therapy to further improve the outcomes in patients with BRAF mutated metastatic non-small cell CL lung. So BRAF is a new target, and the drugs which we have nowadays, they are the new kids in the block. So I'll be discussing about the role of this mutation and the drugs which we have now in our block. So objective of this presentation is to understand the role of BRAF in metastatic NSCLC.
So your slides are not visible. We can see your screen, but not the slides.
1 second. What else? I'll do it again. Sorry.
Yes, sure.
Is it visible?
No, sir. So your
No.
desktop is visible. You need to open your PowerPoint slide.
PPT is not
Okay,
open.
okay. I'll do that. Is it visible now?
Yes, now it's open.
So somebody can share it from their side. I have sent the mail also.
Pooja, you can take that.
I'll share, but your slides are visible now. You can just put it on full screen mode.
Okay. Is it visible?
Yes,
Yes,
sir.
yes.
So first of all, introduction to the BRAF. So the RAS, RAF, MEK, ERK pathway, which you call the MAPK pathway, plays a key role in the cell proliferation. So you can see on the right side, these all are involved in the cell proliferation. The MAP pathway regulates the cell signaling from the transmembrane growth receptors, leading to cell proliferation. They are all proto-oncogenes, and oncogenic mutations in this pathway, including the BRAF kinase mutation, have been reported in the number of human cancers, including CL lung. So BRAF mutation results in constitutive BRAF activation, and it leads to uncontrolled signaling via the MAPK pathway. So it's a rare mutation. It accounts for just 1 to 4% of all the targeted mutations in the non-small cell CL lung, and typically do not overlap with other common mutations like the KRAS, EGFR, ALK. But in contrast to the other oncogenic drivers, the key patient characteristics and indicators for BRAF mutated CL lung have not been well characterized. They do not appear to correlate strongly with age, sex, stage, at diagnosis, or even with the smoking status. However, some studies have suggested that patients with BRAF mutation are more likely to be female and with no history of smoking. So the most common mutation of BRAF is the BRAF V600E, in which valine is changed to glutamic acid. It occurs in around 50 to 70% of such cases, but we have other mutations also. So although it's the most common, occurring around accounting of 50 to 70% of all BRAF cases, other mutations are also identified. So they are called non-V600E mutations. And you can see in the retrospective analysis done by a few people, they have shown that almost 60% of BRAF mutation is of V600, but 40% are of other mutations. So the patient with BRAF V600E mutation have a shorter median DFS and OS than the patient without such mutations, and it leads to a more aggressive tumor. And the patient with such mutations have worse outcomes with the platinum-based chemotherapy, including the disease-free survival, overall survival. And you can see that in this slide, you can see the patient who have been underwent surgery, the time post-surgery, the time to relapse is much higher in the BRAF mutation patient as compared to the wild type. It accounts for both the disease-free survival as well as the OS data also. And in the metastatic setting also, the patients with the advanced BRAF mutation have worse outcomes with platinum-based chemotherapy, including overall response rate, progression-free survival, and OS than the wild type patients. And they respond, and you can see the median OS in the wild type is around 16 months, but if the BRAF mutated is just around 11 months. So till date, the treatment has remained suboptimal for such patients. 33% of patients with BRAF mutation receive the best supportive care upfront first line. Around 60% received best care in the second line setting. Doublet chemotherapy till date has remained the most used treatment for these patients. And in a French registry, they showed that 60% patients receive the doublet chemotherapy. In patients with driver mutations, targeted therapy can be achieved, but as the BRAF is sometimes the only mutation. So in those patients, apart from chemotherapy till date, we don't have any much of a treatment modality available. So the patient with such CA lung without a mutated ALK EGFR currently receive chemotherapy, immunotherapy. This is just to summarize what we do till date. So in the first line setting, we usually give doublet chemotherapy plus minus Bev, and in the second line we can use immunotherapy. And if the patient respond, we can give the maintenance. But if the performance status is poor, most of the times we just declare the patient best supportive care. Till date, we have been doing molecular profiling for CA lung, and histological approach encourages serial testing with companion diagnostic. So, but nowadays we are initially we were doing just for 3-4 targets like the EGFR, ALK, ROS, and MET. But now we have other targets to be seen, which include BRAF, PD-L1, HER2, RET, MET, and even the KRAS has come into the picture. And this has been also documented in all the latest guidelines, be it ESMO or NCCN, all have shown, all have recommended with category 1 recommendation that all these panels should be done with NGS if possible. And if it's not possible with NGS, then we can have the hotshot panel. But testing for BRAF is now part of all the guidelines upfront. So the upfront BRAF testing is essential for all the patients because BRAF does not appear to correlate with any clinical risk factors, and they are more aggressive lung cancers. And targeting BRAF mutation has demonstrated clinical efficacy in patients with such mutations. So a broader molecular profiling can help identify more actionable drivers such as BRAF. So what is the clinical data for the drugs which we have now? So there are 2 drugs, the dabrafenib and the trametinib. They target different kinases in the MAPK pathway. You can see dabrafenib is a reversible, potent, selective inhibitor of RAF kinase, including the BRAF and particularly the BRAF V600E, whereas trametinib it's a reversible, highly selective inhibitor of MAC1, MAC2. So MAC1 and MAC2 come downstream as compared to the BRAF. So you can see in the BRAF wild type, the inhibitory concentration, half median concentration is quite high as compared to the patient we have who have the mutated BRAF. So they work on the same pathway, but they work synergistically. So it has received a DGCA approval. So dabrafenib in combination with trametinib is indicated for the treatment of adult patient with advanced non-small cell CA lung with BRAF mutation. So what is the rationale of combining these 2 things? So the combination has been tested previously also in melanoma also. So combination therapy, it targets the multiple portion of the same pathway and it helps to prevent the development of resistance. So synergistically they inhibit the MAPK pathway and they delay the resistance to BRAF inhibitors in animal models. And in the advanced melanoma setting, it has shown that in the combination, they inhibit the cell growth more effectively as compared to dabrafenib alone, leading to the approval for this combination in the advanced melanoma. And now we have the approval for in the lung cancer also. So the pivotal phase 2 study of this combination was done. And the study was BRF 11398 study. It was a multi-cohort, non-randomized, open-label phase 2 study. And it has 3 arms. It's the 3 cohorts, cohort A, B, and C. In the cohort A, the patient already have received equal to or more than 1 platinum-based chemotherapy. And then the dabrafenib was added and the maintenance setting, dabrafenib alone, at the dose of 150 milligram twice a day. In the cohort B, again, the patient has received previous line of chemotherapy, but in these cohort, the maintenance was given in the form of combination of dabrafenib and trametinib. And the cohort C were the patient who had received no prior treatment and they were found to be BRAF mutated upfront and they were giving upfront dabrafenib along with trametinib. So in all the 3 cohorts, almost around 180 patients, 160 patients were enrolled in all the 3 cohorts. So the primary endpoint was the investigator assessed overall response rate. All responses had to be confirmed based on CIS 1.1 criteria. There was an independent review also. Secondary endpoints was the PFS, duration of response, overall survival, safety, and population pharmacokinetics. So in the cohort A, you can see in the cohort A, 2/3 of the patient was current or former smokers. Nearly all patients had adenocarcinoma, and almost half the patient were in the second line or beyond. Similarly, in cohort B, nearly all the patient was adenocarcinoma, but here the 3/4 of the patient were current or former smokers, and only 1/3 of patients have received more than 2 lines of previous lines of chemotherapy. And in the cohort C, nearly all patients had adenocarcinoma. The current and former smokers, they accounted for around 62 to 63%. So this phase 2 study, it enrolled around 170 patients with stage 4 BRAF mutated non-small cell CA lung. The primary endpoint was the investigator assessed overall response rate. In the cohort A, as I told you, pre-treated patients received only dabrafenib as monotherapy. In the cohort B, they received both dabrafenib and trametinib, and the cohort C received upfront dabrafenib and trametinib. And the majority of patients enrolled were radiant carcinoma and were current or former smokers. So in the cohort A, you can see the overall response rate with confirmed CR and PR was around 33%. But if we see the disease control rate, which includes the stable disease also, it went up to around 58%. And the duration of response was around 10 months. And the PFS was around 5.5 months, and OS was around 12.7 months. Similarly, in cohort B, if we see the overall response rate, it was around 36%, but the disease control rate, which includes stable disease also, it went up to around 70%. So in this graph, you can see the majority of patients in the cohort B experienced tumor shrinkage. You can see the graph, almost 65% patients have oral response rates, and the disease has the disease response varied from the stable disease to a near almost complete response. The median duration of response in cohort B with the combination was 9 months. In the previously treated patients, 50% responses were ongoing at the time of data cutoff. Similarly, in the median PFS also, in the PFS with combination therapy was almost double what has been reported with this dabrafenib monotherapy, that is around 10 months as compared to 5.5 months. In the cohort C patient in whom the patient was upfront started on dabrafenib and trametinib, you can see in these patients also the overall response rates was quite high. Around 65% had the overall response rate with the 75% of disease control rate, with the duration of response ranging from around 11 months to around 15 months. At that time of data cutoff, around 31% were still on this cohort. In the cohort C, you can see again the responses. So majority of patients in the cohort C experienced tumor shrinkage ranging from stable disease to almost complete response. The median duration response in cohort C with the combination was around 11 months in previously untreated patients, which was both in the investigator as well as the independent analysis. So in the PFS with combination therapy was double what has been reported with dabrafenib monotherapy, that is around 11 months as compared to 5.5 months. So efficacy summary, you can see dabrafenib and trametinib were more effective than dabrafenib alone in the patient with previously treated BRAF mutated patients. Overall response rate and PFS were nearly double across all the things, especially in cohort B and cohort C. So safety results, the most common side effects with this combination remains pyrexia, which is seen in almost 35% of patients, followed by asthenia and slightly GI toxicity like the decreased appetite. And in the cohort B, in which the combination was given, they patients have a higher degree of side effects. Nearly all patients experienced more than one equal adverse effects, and almost half had grade 3 or 4 toxicity. There was around 14% discontinuation rate, but you can see around 35% patient required the dose reduction, and around 61 patient required some sort of dose interruption or delay. In this in the safety profile, you can see pyrexia was the most common adverse event. However, only 2% had grade 3 pyrexia. So you can see the various side effects which you see: more pyrexia followed by anemia, and rare patients have some rare confusional state and decreased appetite. Fatal adverse event occurred in 4 patients, but all were considered unrelated to the study. In the cohort C, again, pyrexia was the most common adverse event, occurring in around 65% of patients, and followed by other side effects like the GI toxicity and the anorexia part. So how the steps to pyrexia management in patients treated with dabrafenib and trametinib? First of all, we have to interrupt the treatment with this combination till the patient temperature is more than 38.5 degrees Celsius, and we can continue trametinib in this setting. And secondly, we have to initiate antipyretics such as ibuprofen or acetaminophen. And third, we have to consider oral corticosteroids in those instances in which the antipyretics are insufficient. So again, this is again a chart. First event, we have to administer antipyretic treatment. If clinically indicated, we have to interrupt dabrafenib. We can continue trametinib, and once the pyrexia resolved to baseline, we have to restart dabrafenib at the same dose level. But if the fever is associated with dehydration, hypotension, renal insufficiency, we have to reduce the dose of dabrafenib by 1 dose level. If the second event occurs, we have to manage like the same as for the first event and consider oral steroids more than equal to 5 days, or if clinically indicated. But subsequent event, we have to we have to interrupt dabrafenib. Once the pyrexia resolved to baseline, we have to restart at a lower level, and we have to optimize the oral corticosteroid dose depending on the patient condition. And if the corticosteroid have been tapered and pyrexia recurs, we have to restart the steroids. And if the corticosteroid cannot be tapered or escalating doses are required, we have to consult a medical monitor. And in most such conditions, we have to stop dabrafenib. So the recommended doses for this combination, the dabrafenib starting dose is 150 milligram. That is three tablets, 50 milligram twice a daily, morning, evening. And with trametinib dose is 2 milligram once a day. First dose reduction for dabrafenib is 100 milligram twice a day, and second dose reduction is 50 milligram twice a day. First dose reduction for trametinib is 1.5 milligram once daily, and second is 1 milligram per daily. Subsequent modification has to be done depending on the patient condition. So the trametinib should be taken at the same time each day with the morning dose or evening dose along with dabrafenib. Both of these should be taken without food or at least 1 hour before or 2 hours after a meal. So to summarize this phase 2 study, the safety profile of dabrafenib and trametinib was manageable and similar to those previously reported in melanoma studies. The most common adverse effect occurring across all the cohorts was pyrexia, GI-related toxicities, and some skin reaction. Pyrexia was the most commonly observed AE across all the cohorts, occurring in 33% of patients in cohort A, 46% in cohort B, and nearly 65% in the cohort C. And pyrexia events has to manage with pyrexia management protocols. So these are the reference, and thank you so much.
Thank you, thank you, Dr. Devinder. So the thing is that BRAF is a hello.
Yeah, you're audible.
So BRAF is an aggressive disease. BRAF mutated NSCLC, they are aggressive patients. Means the disease behavior is aggressive. So we need to have some of the drugs which can target, but the hands-on experience are pretty less. Means I have not seen any patient or I have not treated any patient on this dual drug combination. Maybe with time we might see. But of course, the combination has to be given. And of course, when we have to the rationale of combination, we have already that we have to hit that pathway to get the adequate results. So good evening, Dr. Ullas. I can see you.
Sir, yes, sir. Good evening, Dr. Ullas. Sir, have you used this combination?
Yeah. So we have used it in around 6 patients. As you were very rightly mentioning, the major side effect which comes over here is fever. And very rightly said, that you have to see which component has got this, whether it is dabrafenib or trametinib, and then do a dose reduction. Not very toxic. In fact, one of my patients comes from Nepal. So 6 patients, reasonably good, and the eldest patient that I've given is 88 years old from army. So tolerability is not an issue. Get a skin consultation. Although with the incidence of trametinib, the incidence of skin malignancies is lower, but still a baseline skin consultation and within some time a skin consultation once again. It's a reasonably okay tolerable drug. Nothing very sinister about it.
It's like same, sir, as the time we don't have the experience on IO. So at that time we were frightened. Like dual IO, we are still frightened. So maybe
frightened. Dual, I am very frightened.
So maybe when we treat, then we get that confidence of treating the patient and monitoring the effects and monitoring the dose.
No, Dr. Jagdeep, I'll tell you, you're absolutely right. I still remember we did the trial for Ascend 8 for Serotinib, the 750 mg versus 450 mg. That was way back in 2017, my first trial actually as a principal investigator. And at that time the entire experience was about gefitinib and imatinib. हमें लगा ठीक है यार कुछ और होगा, तो उसका we forgot actually to check the sugar and amylase, and the lady went into pancreatitis and everything. So I think very important for all of us is to not think it's an oral drug and things can come, because pyrexia is a very offbeat this thing for interaction for it. Similarly for a MET inhibitor, I know for capmatinib, one of my patients had a creatinine of 2.0. And I was like, iski dose kam karo, AKI ho gaya, biopsy karo, and then my resident came and told me, say, to hona tha. So, important thing is before we read, I actually take out a printout of like, you know, if you have dabrafenib, trametinib, put a FDA access into that, take a printout of that, get it signed by your resident and your consultant and your patient, and then follow it according to that. Now we have an Excel sheet and we are more organized now. But I think, yeah, you're right. It's just because it's an oral drug doesn't mean that it's an easy drug.
Thank you, sir. Dr. Kral, anything from your side, sir?
I had put this combination on one patient. That what time it was not available. It was on special access scheme, and that patient had a coronary event about 8 weeks on treatment. She was responding very well, and she had an acute coronary event, and there is mention of cardiac toxicity and having coronary event related to this combination. So we were not sure. We could not establish whether it at that time it was on special access team by Novartis. So we had to fill the SAE and all those things like you do for a trial, and we had to unfortunately stop the drug. This was, I think, 6 weeks or 8 weeks after starting the drug.
Thank you, sir. Thank you, Dr. Devinder, for all this precise talk. So next speaker is Dr. Amit Deman. Sir is a director of medical oncology hematology at one of the hospitals in Ludhiana, Deep Hospitals. So good evening, sir. Are you there?
Good evening. How are you, Jagdeep?
Fine, sir. Fine, sir. So over to you, sir, for the talk.
Yeah. Please share my slides.
Pooja, can you share the slides of sir?
Yeah. So role given to me is the role of VEGF inhibition in the metastatic non-small cell lung carcinoma. Jagdeep, I will be a little fast and complete task in as we discussed, right? And next slide, please. So as we know, the VEGF they play the key mediator role for the angiogenesis, and which is really required for the progression of the tumor. Next slide, please. So if we see that microvessel density and the VEGF level in the tumor, it shows the poor prognosis compared to when these values are the low, as this is shown in the in this graph, that with the MVD low and MVD high, the patient will have the poor prognosis. Similarly with the VEGF low and the VEGF high. Next slide, please. So the trials which has been done, and they are the major trials with for the bevacizumab in non-small cell metastatic non-small cell lung carcinoma. So these are the phase 3 trials, bevacizumab and the paclitaxel, with another is a point break trial, which is a upfront pembrolizumab with carboplatin, bevacizumab as a maintenance therapy, PEM and BEV, followed by, and the control trial, other arm is the paclitaxel and bevacizumab with carboplatin, and alone bevacizumab as a metastatic as a maintenance therapy. Next, please. So ECOG 4599 trial, the paclitaxel carboplatin alone or with the bevacizumab for non-small cell lung carcinoma. Next slide. So two arms. So in one arm, there is a non-squamous non-small cell carcinoma lung cancer, and definitely exclusion criteria as standards are the brain metastasis, significant hemoptysis, inadequate organ function, or the ECOG performance status more than 1. So in this, the one arm will receive the paclitaxel 200 milligram with the carboplatin AUC6. Another, along with that, will receive the bevacizumab. And no crossover to the bevacizumab was permitted in this. Next, please. So well-balanced trial. So most of the things were quite well-balanced. Next, please. So if we look at the overall survival, median survival in bevacizumab and paclitaxel, it was 12.3 versus paclitaxel carboplatin alone arm, which was 10.3 with a hazard ratio of 0.79 with significant p-value of 0.003. And the 2-year survival, the difference was well maintained, 23% versus 15% in bevacizumab versus no bevacizumab arm. Secondary is the progression-free survival, where the bevacizumab and pacli have the 6.2 month survival, PFS, and paclitaxel and carbo had the 4.5, and where the p-value is well maintained up to less than 0.001. And similarly, overall response rate was again a benefit in the for the bevacizumab. Next, please. So again, this forest plot is showing that this all the patients, those who have all the categories of age, epoch, sex, measurable disease stage, everyone has the advantage with the bevacizumab. Next slide, please. Toxicity profile almost same in both the arms, though if we look at the neutropenia, it was more with the PC arm compared to the bevacizumab arm, and thrombocytopenia was more with the paclitaxel arm compared to the bevacizumab arm. But all over the overall, the toxic profile remained the same. Next slide, please. So there was a real-world retrospective cohort study comparison of survival and hospitalization rates between the Medicare patients with advanced non-small cell lung cancer treated with bevacizumab, carboplatin paclitaxel, and carboplatin paclitaxel alone. It is a retrospective cohort study. Next, please. It was published in the Lung Cancer. So out of 71,000 patients, those who received treatment for the the lung cancer, the BCP, the bevacizumab patient had who were compared were 592 in the BCP arm, and CP arm only 1114. Next, please. And if we see here in this graph that the patient who received the bevacizumab had a better overall survival. So if you look at, there's a difference of 2.1 month difference in the overall survival benefit. And if we, next slide, please. If we look at different age groups, next slide. If we look at different age groups, like those who are less than 65 or less than 75 or more than 75, this gap or this difference was well maintained, but this was better was seen with the patient, those who were age of 75 years or more. Next, please. So final results were, it shows is overall survival performance, PFS and response rate benefit with the addition of bevacizumab to the paclitaxel and carboplatin in the treatment of non-small cell lung carcinoma, and in all the analysis. And in 2014 retrospective analysis of Medicare patient in the CEP database, first-line therapy with BCP was associated with the longer survival and fewer hospitalization than the carboplatin and paclitaxel group only. Next, please. Next, please. Another study is the Point Break study, a randomized phase 3 study of pemetrexed plus carboplatin and bevacizumab, followed by maintenance pemetrexed and bevacizumab. So there were two drugs were used in this, pemetrexed and bevacizumab versus paclitaxel plus carboplatin and bevacizumab, followed by the bevacizumab as a maintenance therapy in stage 3B or the 4 non-squamous lung carcinoma. Next, please. So previously treated, untreated stage 3B or 4 non-squamous cell lung cancer, those received the bevacizumab 50 milligram per kg with carboplatin pemetrexed, followed by the bevacizumab 50 milligram per kg with the pemetrexed, and in another arm the paclitaxel, but the maintenance was given only as a bevacizumab. Next, please. So statistical analysis was done for the intent to treat population and maintenance population. In this, the maintenance population was defined as patients receiving at least 1 dose of treatment at cycle 5. Next, please. In this, the chemotherapy cycles were 4 cycles only, followed by the maintenance therapy. Next, please. So baseline characteristics were well maintained in these trials. Next, please. So if we look at the in the overall survival in the intent to treat population, the 1-year survival was 52.7 in PEM carbo and bev arm versus Beckley's carbo and bev arm, which is 52 and 54, almost same, and even the second year survival was almost the same. But when you look at the overall maintenance therapy, overall survival in the maintenance population, the survival benefit was seen more in patients with the pemetrexed arm compared to the paclitaxel arm. So even the same thing was carried on in the progression-free survival also. The progression-free survival was better seen with the PEM with bevacizumab versus the Pacli with the bev arm. Even if you look at next slide, please. So if you look at the overall survival benefit and progression-free survival benefit, both the PEM with carboplatin and bevacizumab showed. Next slide, please. Shown the better response compared to the Pacli arm. Next slide, please. So the toxicity profile, it was almost the same in both the groups. Next. Although progression-free survival significantly improved with the PEM-C with the bevacizumab, there was no survival benefit as against the Pacli-C-Bev. If we go 2 slides back, so if you look at the overall response rate, overall disease response, so PEM-C-Bev versus the Pacli-C-Bev, there was the same benefit. Overall survival remained the same. Next, please. Next, please. Patient on PEM-C-Bev, next. I'm sorry. Sorry. So patient on PEM-C-Bev achieved a median overall survival of 72.7 months. This study allows on choosing most appropriate based on that specific patient clinical situation and tolerance to toxicity depending on the patient's clinical profile and the patient clinical conditions. So another is the last previous slide, please. So these are the few studies which Aries, SAIL, AVAIL, and E455 efficacy result, where the different chemotherapeutic drugs were used along with the bevacizumab for the comparison. In the Aries, it was the investigator choice. SAIL, it was the investigator choice, and E45599 so it's a paclitaxel and carboplatin. And AVAIL, it is gemcitabine and cisplatin, and AVAIL again, it is gemcitabine and cisplatin with the different doses of bevacizumab. So if we look at next slide, please. If you look at the forest plot, most of the studies have shown it favors the bevacizumab with the p-value of 0.444. But if you look at the confidence interval, so most of the time, except for the ECOG 4599, almost all cross
So
the
request you
midline
to conclude your session in 3 minutes.
right now. Next slide, please. The NCC guidelines says that as per the today's scenario, the immunotherapy is a better combination compared to the bevacizumab. So the NCCN says it is a contraindication to the PD1 or the PDL1 inhibitors, only then the bevacizumab, carboplatin, and paclitaxel. So different combinations can be used with the bevacizumab. Next, please. So maintenance therapy, the rule for the maintenance therapy, next slide. So rule for the maintenance, next slide, please. Next. So NCCN says if whatever the drug has been used in the induction therapy and with the chemotherapy, that targeted therapy should only be used as a maintenance therapy. Therefore, if a biosimilar was initially used as a part of first-line combination therapy, biosimilar should be continued as a maintenance therapy in an eligible patient. Not that we should change to the another therapeutic or the another line of the drug. Next slide, please. Bevacizumab in EGFR and metastatic non-small cell lung carcinoma. So next. So in EGFR, next slide, please. In EGFR, we have EGFR exon 20 insertion. In this, as we know, no good molecule small tyrosine kinase inhibitor plays role. So the chemotherapy along with the bevacizumab is a better choice if given alone as a chemotherapy. So overall progression-free survival and everything, or the overall survival, next slide please. Overall survival is better when it is compared with the chemotherapy. Bevacizumab is given with the chemotherapy. Next slide please. Then we have EGFR, the mutations which are sensitive to the erlotinib. So like the EGFR 19 or EGFR, next slide please. So EGFR 19 or EGFR 21. So if in this the bevacizumab is added with the erlotinib, like in this study, which is NEG 026 study, this phase 3 study. Next slide please. So next, the overall survival, this progression-free survival is better with the bevacizumab arm. So median survival is 16.9 months with the bevacizumab compared with the 13.3 months with the erlotinib alone. Next. So if we go by the different exon deletions, 19 or the exon 21, the result is slightly better with the exon 21 when the combination is the bevacizumab and the erlotinib is given in a combination. Next slide, please. So bevacizumab plus erlotinib versus erlotinib alone as first-line treatment for patients with EGFR mutated advanced non-small cell. Final analysis of the multicentric randomized phase 3 Beverly trial. Next. So I'll go next, please. So here we can see that investigate if the progression-free survival is seen, whether it is a investigator assessed or the blinded independent centrally reviewed trial. The benefit is maximum seen in the first year, and it is extended up to the second year. The p-value of benefit is the hazard ratio is 0.68 with the p-value of 0.027 in the blinded study, or in the p-value is 0.015 in the investigator assessed study. So benefit is seen. Next, please. Is seen with the bevacizumab when it is combined with the erlotinib in the EGFR mutations analysis. Next. Here again, the forest plot is showing that the benefit of adding bevacizumab to erlotinib in the EGFR mutation is good compared to just one. And if we look at the smoking history, those who are non-smoker, overall survival may be little better if it is not given in the bevacizumab, probably related to some kind of some toxicity which has happened. And as we know, the CNS toxicity or the CNS, next slide please, or CNS bleed, which happens with the bevacizumab. So if we look at the efficacy result of the Beverly, in the Beverly trial, the complete remission is just in limited patient, as we know, 1.3%. The progression, the partial response is better with the erlotinib and bevacizumab, which is 70% compared to the 50% in the erlotinib arm. Next, please. So quality of life, it shows that overall quality of life is better with the addition of the bevacizumab to the erlotinib. Next slide, please. If we look at the hypertension, the side effect of the combination, hypertension is little less when we see grade 0 and 2, and when we see more than 3 grade, then it is higher as is expected with the bevacizumab. And the rash is again more with the bevacizumab arm. Next, please. So there are the few trials which are clinical trials of EGFR TKI with the anti-VEGF.
Sir,
as
request you
first-line
to
treatment.
conclude your session in 1 minute.
Yeah. So the overall benefit of adding bevacizumab to erlotinib is definitely there. Most of the studies is showing, and with the significant p-value of less than 0.001 in most of these trials, though it is BELIEVE, Relay trial, and then Artemis trial and Beverly trial. So another trials which are going on, next slide, which are the osimertinib with the bevacizumab, addition of ramucirumab with the osimertinib. So these are the trials which are going on and probably will have the results in the future. In the conclusion, last slide. So there is a definitely benefit of adding bevacizumab to the induction therapy and then followed by the mutation therapy as a maintenance therapy in the non-squamous cell mutation active non-small cell lung carcinoma. Though benefit is seen in all the age groups, but yes, age less than 60, more than 65 years, and male patients, they had the better outcome when bevacizumab added to the treatment. And bevacizumab doesn't add to the significant toxicity except for the hypertension when we add it to the erlotinib therapy. So if we look at the EGFR mutations, the EGFR exon 20 with chemotherapy, bevacizumab is a good option, and EGFR exon 21 with erlotinib is a good option. EGFR 20 zone 19, the benefit was not that significant when it was compared with the EGFR exon 21. And smokers, it is more beneficial compared to non-smokers, as it was seen in the EGFR's trial. And TP53 mutants, it is a better, maybe better option. Thank you.
Thank you, sir. So, sir, your schedule was quite busy, but thanks for spending time for this. So, I think we go to the next lecture. We already did late by 15 minutes. Thanks, Dr. Amit. So, can I,
Thank you, Jagdeep.
Last Patra, sir is a renowned personality. I think he does not need any introduction. Everybody is aware of Dr. Ulas Batra. He is the chief of the medical services in the thoracic unit in the esteemed Institute, Rajiv Gandhi Cancer Institute. So, sir is going to moderate this panel. So, can I make all the panelists, and can they switch on their cameras also?
Can I also request you to allow me to share the screen? I'll invite the panelists. I think Kunal is already there. Gautam, are you there?
Yes, sir.
Gautam is already.
सलमान खान की presentation और हम ना ऐसे कैसे हो सकता है?
तुम सलमान खान हो भैया, presentation तो मेरी होने वाली, इसके बाद होने वाली है. Okay, so we have Kunal and Gautam, and the remaining four I am not that great friends with. So for Kunal and Gautam, I am not using doctor word, but for the others, Dr. Isha, she is an assistant professor and HOD Department of Medical Oncology at KGMU Lucknow. Dr. Mukesh Bansal. Dr. Mukesh is there. I saw Dr. Isha. Hi.
Sir, nice.
Yeah, Dr. Mukesh Bansal, I don't see his name, but I can see Dr. Kanika Sharma, who is an associate consultant at Max Mohali, and Dr. Kushal Gupta from Chandigarh. Okay, hi. So can I start? I'll just share my screen. And my first reactions on when somebody says that this guy doesn't need an introduction or something of that sort, is ki buddha ho gaya hai. I mean, this is one point which I used to say when I used to be presenting people. So thank you, Jagdeep, for making me realize.
Sir, you are authority. You are authority in the lung cancer.
मैं कुमार को बुलाता हूँ, मैं जाके बात करता हूँ उससे वहाँ पे. चलो, let's not waste much time. Let's get to. I think I am already. We don't have much time. So let's discuss about the uncommon, or I have called it the rare mutations in lung cancer in 2022. And I have three important questions, and I think my first question will go to the HODs and stuff like that, So I think Kushal and Dr. Isha will take a big people HODs. How do you define a rare disease? What is the approximate incidence of people living with rare disease in the world? And what is the most rare genetic disease in the world? Anyone who answers this question will get some more questions from my side. Yes, Dr. Isha, you can please put on your camera. So this is just.
Sir, am I audible?
Yeah, you are absolutely audible and visible. And not now. Okay, Dr. Kushal Gupta, any idea?
No, sir, I don't have any idea of a particular sort of a definition.
So, Kunal, anything remembering from the Australian times? Anything? You are muted, Kunal.
Yes, sir. I don't know a complete definition, but I would say which has an incidence of less than 5%, I would take it as a rare disease.
Somewhere close. So any disease which is in USA, you say 1 in 200,000 people. In Japan, less than 1 in 50,000 people, or 1 in 2,500 people. And in European, basically, it basically says that, it is 1 in 2,000 people. So that's the definition of a rare disease. There are approximately 30 million people in the US who are living with a rare disease. I mean, that is too much. I mean, 30 million people with a rare disease is not a rare disease at all. And the most rare genetic disease is a ribose 5-phosphate isomerase deficiency. Just because I had nothing else to speak, so I got this. Small, things for everyone. My subsequent reaction actually is, what is the most uncommon thing that you guys have seen in your practice? Just this thing, just to get the ball rolling. Kushal? Dr. Kaushal?
Sir, melanomas are definitely rare.
Melanomas are rare.
Yeah.
Okay. Dr. Kanika? Well, no, forget the medical oncology. Let's talk about extracurricular. What is the most uncommon thing that you have seen? Me talking sense is one of them. Yes, Dr. Kanika. You are muted, Dr. Kanika.
So lately in the medical only, the last 2 cases that I have seen, one is the sarcomatoid variant of the HCC that we are seeing, and the other is a patient who have presented with the leukocytosis, eventually as an unknown primary and eventually coming out as cholangio.
I think I was talking more about extracurricular, so I'll get Gautam into picture. Gautam is the one guy who will answer me the extracurricular. So Gautam, what is the most uncommon extracurricular thing that you have seen for the family audience? This is not a family. This is, don't go on a literal trajectory. Yes, Gautam.
Brain tumor of ovary.
अरे ये भी एक curricular हो गया है. I mean, they are. So I think common sense is the most uncommon or rare thing that which is there nowadays. So again, just to get the ball rolling. So now let me start with the important thing. So do you think that the incidence of rare mutations has increased in the lung cancer? I'll start with you, Kunal.
I think answer it shortly, answer is yes, but possibly because of increase in diagnostics.
Increase in diagnostics. Okay, Kushal?
Yes, sir, I do agree with Dr. Kunal, sir. Sir, it's definitely increase in the diagnostics and the easier reach of the labs, the high-end labs, molecular labs.
Okay, Kanika?
The same, because of the widespread use of the NGS and everything. It has
approximately how many rare or how many uncommon things you see in lung in the last 6 months or something? Let's just just approximately 1%, 2%, 5%.
1%.
1%. Anyone else? Gautam?
Sir, Kanika and me work together, so 1%.
So then it is 0.5%, no? 0.5 for her and 0.5 for you.
Yes.
Okay, Dr. Isha?
Sir, 1 to 2%, not more than that.
So let's just come on to that. Okay, fine. So let me go to Dr. Isha only. Isha, what do you think? How uncommon or rare or uncommon is exon 20 insertion in your clinical practice?
Sir, to be very frank, exon.
One second.
Yes, sir.
Do you think exon 20 should be uncommon? Should it be classified as common? Should it be classified as rare?
Not rare, but it should be classified as uncommon.
Uncommon. Okay. Kunal?
Yeah, I haven't come across exon 20 mutation, so I would say it is
rare.
There.
Okay. So I'll tell you our data and the Tata Memorial data is by and large together. If you have 100 patients of EGFR mutant adenocarcinoma lung, 62 or 55% of them will be del 19, 35 to 40% will be approximately around L858R, 10% will be having either an exon 18 or exon 20 or a compound or that mutation. And now with amivantamab coming up and launching itself in the next some time, and with NGS becoming so much common, even in our own data, we have 10% of people who have these uncommon or rare mutations. So in fact, exon 20 insertions, I will come to that we are also having a trial right now in first line, that the Papillon study, in which we are randomizing people to PEM-carbo or amivantamab, lazertinib and PEM-carbo. We have already got 4 patients. Overall, global wise, they are ahead of their recruitment. So again, exon 20, which I used to think was rare, but now that we have started looking for it, And now our diagnostic companies, everybody was very right, have started looking for it. Is not so rare anymore. So let's go to this. Kushal, this will go for you. A
Yes, sir.
55-year-old male, non-smoker, stage 4 non-small cell lung cancer, exon 20 insertion, IL cross negative. How will you treat?
So, sir, it will depend on the PS of the patient. If the
PS1.
PS1, then I would go for
Send the
osimertinib.
patient for trial to
Sir,
Dr.
trial.
Ulas.
वो बाद में पहले तो बता तुम कैसे ट्रीट करोगे.
Sir, I would go with osimertinib.
Go with osimertinib. Okay, Gautam.
Chemotherapy, PEMCARB.
Trial is obviously one. Thank you for that. But the only one more slot remaining. So after November, no more slots remaining. So chemotherapy. You will like to give PEMCARB or chemoimmuno?
PEMCARB.
PEMCARB. You don't want to add Pembro?
No.
No. Okay. So we have one chemo. We have one osimertinib. Kunal.
Possibly a VEGF.
Okay, we have one more 3. Okay, this is one more. Possibly a VEGF. You are impressed by Amit Dhiman's presentation.
Not alone, but with
a Paclitaxel or a PEMCARB. Something you will add an
PEMCARB.
PEMCARB. So Kanika works with Gautam, but Kanika, do you differ or you will go with the same?
So first, so definitely for a clinical trial. Otherwise, chemotherapy alone.
Okay, Isha?
Dr. Glass, can I add to this?
Yeah, sure.
So I'll go with the afatinib in this patient.
We'll go for the afatinib in this patient. Okay, fantastic. Okay, Isha?
Sir, chemo plus bevacizumab.
So we have 2 chemo
PEMCARB plus bevacizumab.
Or a PEMCARB plus bevacizumab. And this is what the exon.
There is some data regarding efficacy of afatinib also in exon 20. So
I will show you some data. I will show you some data on that. Okay. So the first and the most important thing is, this is more of a lecture rather than giving anything else. All the exon 20 insertions are not created equal. So right now, the first question which normally comes to my mind is, how did you diagnose exon 20? Whether it was on the basis of COBAS or TheraScreen, or did we do an NGS? There are certain exon 20 insertions which will respond to even afatinib and osimertinib. Around 10 to 15% of them. 85% of them will not respond to afatinib and osimertinib. So that is one. You have to do an NGS. There are certain exon 20 insertions which are near the loop, which will respond better to mobocertinib, although that was a concept before, and some ones will respond better to amivantamab. But now the latest data basically says that if you do not have a sensitive exon 20 insertion, probably amivantamab and mobocertinib is second line are by and large equal. That is one. The data of amivantamab, mobocertinib, poziotinib is not in the first line. That data is in the second line after failure of first line chemotherapy. The third question is, are they available in India? Amivantamab is now getting commercially available probably in the month of November. Mobocertinib is not yet available. Even the compassion access is not yet available. Poziotinib, we may have a trial coming up in the later times. So this was the mobocertinib data in the exon 20 insertion. And for the lack of time, this is a second line trial. After the failure of this, you have a median overall response rate of 25-28%, a PFS of 7.3 months, and a median duration of response of 17.5 and an OS of 24 months. This is what I wanted to show. So this is what people were talking about. And here is where mobocertinib, again, if you read the indication, this is after platinum-based chemotherapy. Amivantamab also is after chemotherapy. Osimertinib was after 1 line of treatment. Look at the responses, 24%, PFS 9.6 months. But the number of patients are very, very, very small. That is only around 21 patients. Poziotinib, again, very, very toxic. So right now, if you have done an NGS and you have an exon 20 insertion mutation, your first choice of treatment will be chemotherapy. That is pemetrexed, carboplatin, plus minus bevacizumab is everybody's guess. I am not a believer of bevacizumab, so I don't want to use that. However, absolutely okay in people who want to give bevacizumab. The second line data approval right now will be for amivantamab because amivantamab is going to get available. Mobocertinib is an excellent equivalent choice. That is the second thing. The main duration of difference will come up over there in the toxicity. Mobocertinib is your typical second generation EGFR TKI. you will get diarrhea, you will get paronychia, you will get rash and everything. For amivantamab, the major problem which will basically come is an infusion reaction. For all those people who have given amivantamab, it has got a 66% chance of infusion reaction. You give amivantamab like a paclitaxel hypersensitivity reaction, people do go into kind of grade 1, grade 2 kind of a hypersensitivity reaction. That is the major difference about that. As far as the activity is concerned, by and large, the activity is by and large the same. There is not much of difference between mobocertinib and amivantamab. So my conclusions or my thing would be so first of all, see whether it's a PCR or a non-PCR. If it's a PCR, get an NGS done. See if you have a sensitive mutation which can be given with osimertinib or afatinib. Afatinib is good enough for them, but there's very hardly 10% of people. You have an S676I or something. If not, give chemotherapy. Try for amivantamab or mobocertinib in the second line. That is what probably I would do. Otherwise, and these are the future lines of treatment, and this is the trial that we are having. But I mean, by and large, only I think not more than a month or something is available for this trial. But that's a very good trial because now you are comparing amivantamab PEM carbo versus PEM carbo in these people, and in these people you will give amivantamab or progression also. So even if they don't come into the first line, they'll get in the second line basically. Anybody wants to ask anything on this?
So the HER2 subset is also included in this exon 20?
Yes, they are saying HER2 insertion or exon 20 will be. It's not the typical HER2 new mutation. Yeah. Some of these exon 20 are included in that also. Yeah. So HER2 subset also is included. That is why once you have this report, talk to your molecular pathologist, and then I always say, talk to them and then come back from there. So exon 20, for me, the take-home messages are no immunotherapy, only chemotherapy. Rarely afatinib and osimertinib, typically pemetrexed carboplatin followed by amivantamab in the second line. That is what I would really suggest. Gautam?
This trial is upfront chemo with amivantamab.
Yes. So amivantamab plus PEM carbo.
And then you continue amivantamab and PEM.
Yes, continue amivantamab and PEM.
Okay.
Versus
sir, there's one question, sir.
Yes.
Sir, can we send a patient to get enrolled for this trial?
Yeah. Only 1 more month.
If exon 20 insertion is positive?
Yes, you can.
Okay.
Send with a block and no chemo.
Okay.
Because the block needs to go over there. That is why. Okay. So that is one. We have time, Dr. Jagdeep, because I have some very interesting cases actually.
Yes. Okay. Sir, we are keen to listen to you.
Yeah. So we have the second case over here is for the HER2 new mutation. This is a real case. You have a non-smoker 70-year-old female who came with massive left pleural effusion. A thoracoscopy and biopsy was done, which revealed adenocarcinoma, EGFR IL cross 1 negative, PDL1 70%. And we got an NGS done, which comes as HER2 new mutation. Now, Dr. Isha, you told no HER2 new mutation. So I told we have a case over there only. So now tell me, what will you do? Will you give chemotherapy, chemoimmuno, only immuno, chemotherapy, trastuzumab, TDM1, TDX, PTH? Kunal to पीछे बैठ गया. Kunal ने कहा छोड़ो यार. Yes, Dr. Isha.
Anti-HER2 therapy.
So you will give anti-HER2. Which anti-HER2 therapy?
Sir, would have liked to give trastuzumab deruxtecan, but it's not available. So trastuzumab alone plus chemo. Trastuzumab plus chemo.
Give option number 4, chemo plus, you will give trastuzumab plus PEM carbo.
Yes, sir.
Okay. What about Dr. Kushal? Kushal ने भी ना वीडियो बंद कर लिया है. सब लोग धीरे-धीरे करके जो है ना वो वहां कर. चलो अपना वीडियो ऑन करो सबको सब. Yes, Kushal.
Sir, I would agree with Dr. Isha. Just chemotherapy and trastuzumab, or just chemotherapy alone. That's also an option.
Just chemotherapy alone or chemotherapy and trastuzumab. I think Gautam has left. So Kanika, you are covering up. You have 2 options. One for you and one for Gautam.
Sir, TDM1.
TDM1, fantastic. India is a democratic country. Okay.
Because we have this case with us, so we have treated with the TDM1.
अभी चलो 5 मिनट रुको, मैं तुम्हें दिखाता हूँ तुम्हें क्या करना चाहिए था. चलो बताओ. Kunal, what will you do?
Yeah, so trastuzumab deruxtecan if the patient is affording, that is first option, and if not, TDM1, and if not affording for that, then I would give only chemo.
Okay. So I will show you some data, and I mean, just in case all of you think that your job sucks right now, I mean, just think you could be on this, you could be having this job also. At least this is better than that job. So this was the data which was very, so I have, it's not that I have not given. I have given Herceptin plus Paclitaxel, I have given TCH, and I have given everything. In fact, I forget that I have given, I have a series of 12 patients which I have given, and probably made a Mickey out of myself. So this was the data of pertuzumab, trastuzumab, and docetaxel in people who had a HER2/neu mutation. And this was a small number of patients actually in this. And what it basically found out was your median PFS was only 6.8 months, and the median OS was only 17.6 months. So a very important thing over here is typically, and again, having said that, I have given trastuzumab to all my patients. It is not the first choice of treatment. I mean, HER2/neu mutation or a HER2/neu by, first of all, you should not even do an HER2/neu by IHC. And even if you have a HER2/neu mutation, adding Herceptin, trastuzumab in the first line, even you can see over here, Perjeta and trastuzumab doesn't really add too much, just an overall response of 28%. First line of treatment, by and large, remains only and only chemotherapy. This is the first line of treatment again. Second line of treatment, TDM1, you have a median PS of 5 months. 50% of patients had taken a prior HER2/neu therapy. The drug that what everybody said was right was trastuzumab deruxtecan, but that also is, this data was by and large in second line setting. This data is not in first line setting. So to me, what we do right now is we give only chemotherapy in the first line. On progression, if the patient does not have anything, I give TDM1, and then obviously we apply for the TDXD drug basically. And again, this is what I am telling you again, unclear role of trastuzumab antibody-based conjugates. Chemotherapy is still the standard of care, not my words. This is the words of the discussant over there. Second line, play around with TDM1 and TDXD basically. But if you can do more about it, send the patient to us. We have a first line trial of TDXD. We will give, and the people, I still do not have a single patient in this trial. Why we don't have? Because they want a chemotherapy naive patient. In chemotherapy naive patient, the HER2/neu NGS report takes 2 to 3 weeks to come, and by that time nobody is willing to wait. But if somebody has a patient over here, we'll be happy to take the patient. And this is again TDXD versus chemotherapy. Yes, Kunal, you have a point.
Yes, sir. Just wanted to check the data that you showed was for lung Destiny Lung 01.
Yes, I think so. I don't know. I'm not sure.
So is that are they not taking low HER2, the one?
No. Lung mein you have a HER2/neu mutation.
I think
nothing called
correct, but that is why I just wanted to check. Are they taking in this trial?
No. So I mean, lung 4 mein jo hai, it is basically about the NGS. NGS showing a HER2/neu mutation. No HER2/neu. That is for breast cancer people right now. Yeah. So this trial also, if you have a first line patient, we have the data for this. Otherwise, if you've already given chemotherapy, what we do is we give PEM carbo for the first, so whatever chemo for the first one. On progression, give TDM1 and then take it from there. So I think 2 cases is enough. Jagdeep, I would love to discuss more, but I think we are already 10 minutes ahead of time. So is that okay?
Thank you so much, sir. And everybody has gained a lot of knowledge.
Okay, the last one. I'll just tell you last one. Jagdeep, one second.
Sure.
Yeah, so this is also the last one, KRAS mutant. And why I'm telling you again is because we have a clinical trial for this also. So this was the KRAS 12C. I'll just show you the data. This is the contrast one. So this is a second line data. Again, a lot of time people will come and ask us that we have a KRAS 12C patient. In a KRAS 12C patient, if you have a mutant KRAS 12C, please go ahead and give them chemotherapy plus minus immunotherapy. For a KRAS, absolutely you can go ahead and give immunotherapy. You can give pembro-pem carbo. Once the patient progresses, now this trial is running and recruiting patients with us in the second line, where you can give them, patients will be randomized between docetaxel versus the Novartis wala KRAS 12C. This is not a sotorasib. This is Novartis developed KRAS 12C, and we can give this also. So this is again, we have just started recruiting for this trial for this patient. So thank you for more than a panel discussion. This was more of a me talking, and so sorry for not giving you guys time, but that's it. Thank you.
That was how it was supposed to
Thank
be.
you, sir.
That is not
So
the way it was supposed
what
to
is
be.
your, just to ask you, what is your current methodology in terms of evaluating a new patient with non-smoker adenocarcinoma lung? What test are you ordering?
So Kunal, whether it is a smoker or a non-smoker, everybody. Everybody from me gets a. So we have an in-house lab. So what we do is we get a biopsy. In the biopsy only we ask for reflex markers for IHC and PDL1. So if a patient comes to me today, by 2 days or 3 days time, I'll get the adeno or squamous P40, TTF1 and a PDL1 report. If the report
PDL1 by
SP263.
Okay.
So we will in 3 days time have that report. We don't act on that report. The moment we have that report, if it is a non-squamous cell carcinoma, if a non-squamous carcinoma, I send for an NGS. Now, since we have volumes in Rajiv Gandhi, what we have negotiated with our molecular pathology is we do EGFR by single gene testing, we do ALK by IHC, and irrespective of the reports, we send everybody for NGS. So then the cost of the NGS has come down. So the NGS cost is now 30,000 rupees, but my EGFR report I'll get in 3 more days time. My ALK by IHC report I'll get in 1 more day time. So normally within 5 to 6 days, I have the result of EGFR, PDL1 and ALK. Which by and large takes away all, and in 2 weeks time, I have the result for my NGS.
And this NGS is kind of routine NGS that you will do for all solid tumors, or it's
no. It's a typically lung based this thing which will have a DNA, RNA. RNA will have fusions. We'll have fusions for almost everything. We have fusions for MET, HER2, ROS, RET, NTREG. We have done for that. So that's a panel which is very close to my heart. It's almost like my baby. I have the one who has designed this panel in conjunction with my molecular pathologist. So that is the way it is. So normally within 15 days, within 3 days time, we have the biopsy report. Within 5 to 7 days time, we have the EGFR ALK report. Within 2 weeks time, we have an NGS for everyone. So
and for
and your wife is there behind you.
Yes, sir. The time is up. So RNA, you need a fresh biopsy, isn't it?
For DNA, RNA, both of them you need a fresh biopsy.
No. For DNA can be done on tissue block, paraffin embedded, but for RNA, it has to be a fresh in RNA later. No.
No, nothing. You can your DNA will get this thing to RNA, translated to RNA.
Yeah.
So you don't.
Okay.
The same fresh biopsy, you make a block and then you shift from DNA to RNA. And my only this thing is, we should identify a lab. Don't send it to everyone. Identify a lab, find the molecular pathologist in that, make friends with him or her and talk to them. That's the only thing, that's the only way how medical oncologists are going to learn molecular oncology and make the life better for us and the patients.
Thank you, sir.
Thank you. And sorry for not letting you guys speak. Sorry.
Thank you, sir.
Sorry. Bye.
Thank you all the panelists also. This was really a brainstorming session. Next session is by Dr. Charu. She is a pathologist at MedGenome Labs, and she's going to speak on the biomarkers of IO in the lung cancer. Over to you, Dr. Charu.
Yeah, thank you so much, Dr. Jagdeep. Just to correct, I'm not the pathologist. I am from Scientific Affairs Department, and I'm basically a genomics person. So, yeah, no issues. Thank you so much for giving us this opportunity to discuss about biomarkers, which is one of our main area which we work at MedGenome. So, I will not be going into more details around what immunotherapy is. As we all know, it's a major breakthrough in terms of giving the first line treatment to the lung cancer patients. Since the PD-L1 testing and all the drugs that have come in, it has modulated the treatment for lung cancer along with chemotherapy. So there are a lot of FDA approved immunotherapy checkpoint inhibitors that have come in the past few years and changed the landscape of how we treat, how the treatment is given in terms of PD-1 or PD-L1 inhibitors. So there are few inhibitors which are PD-1 inhibitors, and the others are PD-L1 inhibitors. So basically, PD-1 is present on the T cell, and PD-L1 is present on the majorly on the tumor cell. So this is the mechanism of action of PD-1 and PD-L1 inhibitors. In the absence of any inhibition, this interaction between PD-1 and PD-L1 along with CTL4 causes the inhibition of T cell to act upon the tumor cells. And when the patient is given PD-1 and PD-L1 inhibitors, it leads to inactivation of this particular receptor interaction, and it leads to the activation of T cell, and hence of it interaction of PD-1 and PD-L1 generates an inhibitory signal, an activation signal for the T cell to kill and act upon the tumor cell. So that is what is the major mechanism how the PD-L1 and anti-PD-L1 drugs are working. Now, biomarkers for the use of immunotherapy in terms of lung cancer specifically, there are certain new interesting markers that have come up, but still needs to be established. So we know the routinely done biomarkers are TMB, tumor mutation burden, MMR, MSI, DDR related genes like KMT2A, KMT2B, KMT2C, POL1, POL and POL D1, DMT3A. Then we have KRAS playing a little role, and STK11 along with TP53 and KMT2C. So these are tumor specific genes which also have a little presence in terms of working on the response of immunotherapy biomarkers. So coming to particularly different biomarkers. So first one is PD-L1. So as we discussed, the mechanism of PD-L1, the expression of PD-L1 has been identified to be prognostic marker for good response to immunotherapy. And PD-L1 expression in the tumor cell is typically detected by immunohistochemistry using the monoclonal antibodies, which are specific to human PD-1 molecule. So this mechanism of action I just discussed. Then we have different clones of PD-L1 that are available for different drugs, like 22C3 for pembrolizumab, SP263 for nivolumab and ipilimumab. So in terms of FDA approvals, we have FDA approval for pembrolizumab in the first line, along with the chemotherapy drugs, and the scoring which is done is total proportion tumor score in case of non-small cell lung cancer. For SP263 also it is scored with the tumor proportion score, that is the TPS scoring. So in case of lung cancer, CPS scoring is not indicated in any of the clones which are being used, and we can only give a tumor proportion score, which actually is the amount of tumor cells that are showing a positivity of PD-L1 expression. So according to NCCN guidelines, patients who are PD-L1 positive and are negative for actionable biomarkers with a percentage of 50% or more, they are given a first-line therapy option for pembrolizumab, atezolizumab, and all these different drugs, which I think you guys have just discussed. I mean, the clinicians have given a very good input on that, so I will not be talking upon the drug preferences. However, if the PD-L1 positivity is 1 to 49%, then in the first line therapy, they are not given as individual drugs. They are just given as options. In certain circumstances, you can give as a category 2B as a pembrolizumab. So percentage positivity is also important to be known in case of lung cancer, so that you can decide on the line of therapy. So further, if it is less than 1% and it is negative for actionable molecular biomarkers, EGFR, ALK-ROS, to all those 9 genes which are indicated in NCCN guidelines, then you have to go for a systemic therapy maybe. However, on progression, maybe we can look upon using independent of PD-L1, the use of IOs. Next is tumor mutation burden. It is approximate measure of total number of tumor somatic mutations basically. So tumor mutation burden is directly related to number of somatic mutations that are present across the whole genome. High level of TMB indicates that the patient will have a good anti-tumor immune response, and it is high in patients who are smokers or former smokers, and low TMB is more commonly to be found in never smokers. According to principle of using TMB is basically that there will be more number of new antigens in the cells, and there will be a stronger immune response against the tumor. Melanoma and non-small cell lung cancer are basically the two major cancer where high levels of TMB were detected, and consensus of scoring the TMB is that mutations with greater than 10 mutations per megabase pair is low TMB, and greater than less than 10 is low TMB, and greater than 10 is high TMB. Now, if we look at the estimation of TMB, it's very important when you are looking at the estimation of TMB, because generally the panels which are used these days are, targeted panels. We are not looking at doing the whole genome sequencing for calculating the TMB. We just do it for almost 300 to 800 genes, which can identify the targetable genetic aberrations in the form of point mutations or other kind of variants, and we extrapolate it for the whole genome. So there has to be a certain coding region which has to be covered, like which has to be greater than 1.5 MB. If it is not greater than 1.5 megabases, then your TMB estimation can be incorrect, and the minimum number of genes should be 300. So next important thing is tumor infiltrating lymphocytes. This is an upcoming area where these lymphocytes which are present around the tumor cells create a tumor microenvironment. They could be CD4 positive, CD8 positive T cells, B cells, and NK cells. So they are being investigated as a predictor to response of immune checkpoint inhibitors. However, we have not seen any concurrent data around this. This is still under, I think, clinical trials. Next pathway is your MMR pathway or DNA damage response pathway. So here we have for the mismatch repair system, which is your MSI, which can be done by PCR, immunohistochemistry, and also by NGS these days. So there are three techniques which are being used these days. However, in case of lung cancer, the specificity of MSI testing is not well established. There are not good correlation there. But if you look at other histone methylase transferases, that is your DNA damage response genes like KMT2A, KMT2C, or STD-D2, they are associated with better results for immune checkpoint inhibitors. In particular, if you look at POL and POL-D1 gene, they basically are involved in DNA replication and repair, and they are associated with longer median OS in non-small cell lung cancer. If you look at DMT3A, how it is related, it is found to be most significant alteration in responders. So it indicates a good, if there is a mutation in DMT3A, it indicates that the patient is likely to respond better to immune checkpoint inhibitors versus the non-responders. Certain tumor-specific genes like TP53, they are being correlated with PD-L1 expression. So low TP53 mutation can predict the PFS benefit in patients treated with immune checkpoint inhibitors. TP53 variant allele, which has where there is high VAF, that can indicate that the patient shows more immune cell infiltration and higher PD-L1 expression. Also, a combination of mutations in TP53 and KMT2C can predict the response patients to immune checkpoint inhibitors. So specifically, if you look at a study, a PFS was slightly better in patients where there was co-mutation, possibly because co-mutation of TP53 high the initial CD8 T cells and initial B cells, and can give you a tumor microenvironment where the immune checkpoint inhibitor can work better. Similarly, KRAS gene has been correlated with an inflammatory tumor microenvironment. So it gives you a good response to immune checkpoint inhibitors in advanced patients. And if you look at STK11, it is poorly associated it is associated with poor prognosis in KRAS positive patients having lung adenocarcinoma who are treated with first-line immune checkpoint inhibitors. So such kind of findings have become I think these are very important in terms of, because if you are doing a broad molecular profiling where you are looking at more than 300 genes, in those cases, you can definitely understand the use of such biomarkers and map your therapy selection accordingly. Another important thing is MDM2 amplification and CDK and 2B loss, which is correlated with hyperprogressive disease. So if these mutations are present, they can lead to a hyperprogression of the disease in patients who are treated with immune checkpoint inhibitors. So timely detection of these patients is very important so that you can look for alternate treatment option and improve the outcomes for these patients. So this is just a list of all the biomarkers which I have discussed: tumor mutation burden, PD-L1 expression, mismatch repair deficiency, microsatellite instability, mutations in STK11, POL1, POL2 disease. So all these things, I think some important markers I have discussed, and use of such markers can help in terms of clinical, better clinical outcomes. So that is it from my side.
Thank you, Dr. Charu. So it's a good insight to the molecular pathology, basically in the lung cancer, and we are dealing, and the high TMB and all these things. The cancer which are very aggressive, they are prone to have more mutation changes, and they are more usually are associated with the more high TMB. And with those, we can get those subset of the patients which can respond to some sort of the immunotherapies.
Correct.
So thanks for all your update, and this is a nice talk which can give us this, which gives us this idea.
Thank you for your opportunity. Thank you so much. Yeah.
So next session is by Dr. Sandeep Jasuja. So he is another renowned authority in medical oncology. Is sir here?
Hello.
Hello. Good evening, sir. Sir,
good evening, Jagdeep. Thank you very much for giving me an opportunity.
Sir is a
person.
Yes. Sir, just
can I share my slide also?
Sir is basically the head of the department of the State Cancer Institute, Jaipur, and my privilege that I got sir on this webinar, and I met sir just 2 months back, and it was nice meeting with you, sir.
So are you seeing my slides on this?
Yes.
Yeah, okay.
Yes,
thank you very much, Jagdeep.
Can you put on sir slide modes?
So can I move my slides?
Slide mode. Yes.
Yeah, okay.
Thank you, sir.
At the outset, I would like to thank Dr. Jagdeep for giving me an opportunity to interact with you guys and who is who in lung cancer and breast cancer. And really, I'm very grateful to you for giving me an opportunity. As you know, this is the pharma sponsor session, and the job assigned me to just discuss on the atezolizumab in first line treatment of NSCLC. So I will limit myself to this drug only in the treatment or management of the lung cancer. So this is my disclaimer, which is given by Roche people, and which is on your side, sir. So coming to, as we know that now the era is the immunotherapy. So I will just limit myself to this immunotherapy, especially on atezolizumab in the treatment of lung cancer. And we have main 3 study which we will discuss in my this short time, and I will try my best to be in time to discuss this study. And the main study are IMpower 11 110, IM power 150, and IM power 13. So as we know, the non-small cell cancer is slow growing tumor compared to small cell cancer, and the overall response depend upon the target mutation driver and any target therapy. And also NSCLC account about 80 to 85% patients of all lung cancer, and out of 85% patients, 15% patients are never smokers. So this is very important point in NSCLC. Again, 50% patients are not smoker, and median age of presentation is 17 years. In our India, it's a little bit younger patient present to us, about 60 years. And also out of this, half patient metastasized in advanced stage when presented to us. So we know the target agent like ALK and EGFR are blockbuster in this treatment of patient, and they have improved overall survival and improved overall response rate in this patient. So if we see the evolution of lung cancer in long back, when we don't have an AT, we have only chemotherapy in the treatment of NSCLC and also in the small cell lung cancer. And over a period of time, we have chemotherapy anti-angiogenesis, and now then divided into the molecular pathology like driver mutation, and this is the major breakthrough in the treatment of lung cancer and management of lung cancer. And now we came up with the immunotherapy in current era, and we have this also drugs available with us in India also. So if you look at response rate and overall response in patient of driver mutation, they have very good response and they have very good overall survival compared to chemotherapy alone or observation alone. And this is the subset where we can offer very good drug like any TKI. We have many lines of TKI, and we have also drugs available for all driver mutation positivity. But somehow, unfortunately, French cooperative thoracic intergroup published a data of 18,000 patients of NSCLC, where they have shown that a major chunk of patients, of 35%, have unknown mutation or don't have any actionable biomarkers. So this is the subset where we have to work upon, and the immunotherapy plays very good role in this subset. So we know that there are many different immunotherapy works in NSCLC, like we know Pembro, we know Nivo, and we know atezolizumab, but I will limit myself to Atezo in this patient, in this my presentation. And the main three trial which have established the role of atezolizumab is the 1110, which established the role and address the issue of monotherapy of immunotherapy as a monotherapy compared to chemotherapy in PDL selected high patient in a chemo-naive, and the 130, where the patient cannot tolerate the steroid, in like a diabetic patient, a hypertension patient, or patient who are this steroid are contraindicated in immunocompromised patient. Then this issue is also addressed in the 13 IM power study, where they have used chemotherapy with napacli and atezolizumab versus plain atezolizumab. And IM 150, which is very important landmark trial, which addresses the issue of adding atezolizumab to the standard of care of bevacizumab plus paclitaxel and clinical benefit, and also can we replace the bevacizumab with atezolizumab? These issues are addressed in all these landmark trials. So IM power 1110 included squamous as well as non-squamous, both type of patient, and this is well-designed trial, and randomization was done in 572 patient in 1:1 ratio, and the patients enrollment was the stage 4 non-squamous or squamous patient having PD-L1 positivity at least more than 1%, and patients were randomized to atezolizumab followed by maintenance atezolizumab 3 weekly, compared to non-squamous received carbo, cisplatin or cisplatin plus pamitaxid, and squamous cell patient received cisplatin gemcitabine followed by PAM maintenance in non-squamous cell, and best supportive care in squamous cell carcinoma, and the follow-up was done till progression or a loss of clinical beneficiation in both arms. So if you look at the prevalence of PD-L1 expression in this 110 trial, IOM-110 trial, and they have divided the expression of PD-L1 in 3 groups. Group 3, where their expression was more than 10% in IO arm, compared to more than 50% in chemo arm, and group 2 or 3 more than 5%, and when we include all group 1, 2, 3, then at least 1% there should be more than 1% PDL expression there, and 100% patient are selected only if the patient have more than 1% PDL1 expression. Looking at the baseline characteristics, this is well matched and balanced, well-balanced trial in between the both arm and PDL1 subgroup, and the characteristics are age less than 65, male, white, Asian, never smoker, non-smoker, ECOX proportion. This is well-balanced trial, and in group 1, 2, 3, and if we see the subset of group 3 where there is at least PDL1 should be more than 10%, then all parameters, this is well and balanced trial. So coming to the overall survival in this subgroup of 3 where there is more than 10% more than 10% of PDL1 presentation, look at the overall survival curve where this is early separated and have overall median survival in 13.1 month in chemo arm compared to IO arm 20.2 months. So this is significant. There is a major advantage of IO when we use in this patient of specifically in patient of PDL1 high and group 3. And if you, the landmarks are 6 months where they have compared the arm A at you compared to the chemo arm, and 76%, 76 month is 76% have the 6-month overall survival compared to 70%, and at the 12-month landmark 64% patient have this is overall survival. They have survived compared to 50% in chemo arm. And if we go down to the subgroup analysis, then we again see the clinical benefit in overall survival in all subset of analysis. Like if we see the age, male, female, white, Asian, never smoker, or common current smoker and previous tobacco user, and squamous or non-squamous ECOX performance, except in the patient who are never smoker and also age more than 75. Otherwise, the hazard ratio is less than 1 and favor the immuno arm in this IO1 powers. And when these patients are progressed on immuno or chemo arm, they are crossed over to the another therapy like chemotherapy, immunotherapy, and target therapy. And 1/3 patient have also received immunotherapy in chemotherapy arm and also chemotherapy in atezolizumab arm. So this is also again shown that the using the upfront atezolizumab does not interfere in the subsequent therapies, and so we can use safely subsequent therapy even in the patient who are we use this immunotherapy upfrontly. Looking at the progression-free survival, also it is separate. The curve are separated very initial phase in group 3 where the PDL1 should be more than 10%, and the progression-free survival is also again favor the immuno arm 5 months compared to 8.1 month in immuno arm compared to 5 months in the chemo arm. And also at the 12-month progression-free survival is 36 months compared to 21. Look at the progression-free survival 12 months, and this is almost double in the immuno arm. So if we compare overall response, again it favor the immuno arm, and 38% patient have overall response rate compared to 26% patient in chemo arm. So if we discuss about the safety profile, so safety in terms of safety profile, immuno is also well tolerated compared to chemotherapy, except in the immune-related adverse event. And we all know that this happened because of this is immunotherapy, and otherwise it's well tolerated in all parameter, and grade 3, grade 4 adverse event are also similar in the chemo and immuno arms. And all there's no major difference in the all adverse event more than 5% in both arms. So this is well tolerated, and little bit have a high immune related effect in the immuno arm. So to summarize, that is atezolizumab is promising first line. We can use this first line patient with PD-L1 high NSCLC, and especially in the patient who have high PD-L1 compared to chemo arm. And this is the safety of the atezolizumab is less or more equivalent to chemotherapy, and we can use it safely and have a good option for us in the treatment of the patient of NSCLC or even squamous cell carcinoma. Coming to IM15, which is specially designed for non-squamous cell patient, and this is the phase 3 study which addressed the issue of combining the atezolizumab plus standard chemotherapy and bevacizumab, and have 3 arms where they used ati with carbopacli first arm, and the second is the ati carbopacli beva, and third one is the carbopacli beva, and followed by atezolizumab maintenance, atezolizumab plus bevacizumab or bevacizumab. So this is well designed, randomized 1:1:1 ratio, and they all have patients were tested for PD-L1 expression. And this is designed to 1:12, almost 1200 patients. And the endpoint is the till progression or have loss of clinical benefit. So we know the bevacizumab works on many factors to control the progression of lung cancer, and bevacizumab also inhibit the VEGF-mediated suppression of dendritic cell maturation, and also it normalizes the tumor vasculature, resulting in increased infiltration of T cell into the tumor. And also decreases the activity of MDSC and Treg cells. So this and chemo also induce the cell death that target the release of antigen. So this all factor combining and works synergistic with the atezolizumab, and which ability to restore the anti-cancer immunity through the T cell mediated cancer cell killing, and also it further enhance the bevacizumab VEGF mediated immunomodulatory effect. So this when we use this all drugs, they are synergistic to each another. So this is the basic and hypothesis behind the combining with these all drugs and to use in these patients. So this is IM1505 trial is again well balanced trial on all parameters like age, sex, tobacco, non-tobacco, never smoker, liver metastasis, EGFR, ALK, KRAS, and PD-L1 expression, group 3 or group 1 patients. Or even they have also recruited the patient who have even PD-L1 negativity in these patients. So look at the subgroup analysis. 14% patients have metastasis of liver at the presentation, and this is we know this is very poor subset where they behave very aggressively when the patient have a liver metastasis at the presentation. And also they have included 18% patient of EGFR mutation who are treated previously with all EGFR kind of treatment. So coming to the overall benefit after survival of benefit in when we add the atezolizumab in the intention to treat patient of group B versus comparing group B and group C, where we use bevacizumab, atezolizumab, chemotherapy, and chemotherapy in group B, and compare with the bevacizumab and chemotherapy alone. And look at the survival. There is again benefit of median overall survival of 19.5 months when we use atezolizumab with the beva and chemo CP cisplatin or cisplatin paclitaxel or carboplatin paclitaxel compared to median is 14.7 seen in the bevacizumab plus chemo arm. And at 12 months, overall survival was 67% compared to 61%. And at 24 months, it is almost 1.5 time favoring the atezolizumab arm compared to beva plus chemo arm. So absolute, we found 4.5 months of overall survival over the beva plus chemo arm. And overall response and duration of response again very high, irrespective of high PDL1 or low PDL1. And look at the high PDL1, it is 56%, 9% compared to 49%, and even this is also maintained good response in where PDL1 is negative, 51% compared to 36% patients in arm B compared to arm C. So overall benefit, survival benefit was also observed across all arms when we add the atezolizumab in the bevacizumab plus chemotherapy arm, and irrespective of PDL1 negativity, low or high. But yes, in high, the response is high, and we should think about the adding of atezolizumab in the bevacizumab standard care.
Sir, request you to conclude your session in 2 minutes. Thank you.
Okay. So I am 1.5 power again. We added the EGFR, they added the EGFR positivity and effect of TKI they address, and I've shown that when the patient subset of 73 patients which have used this TKI sensitized and also prior TKI arm, and have also very good response in these patients, and there is difference of median 9.7 months compared to 6.1, 3 month absolute difference of overall survival when we use this standard treatment even in EGFR mutation positive and ALK. And overall survival benefit is also seen in this arm C compared to arm C in EGFR mutation positive, and overall response rate again 71% compared to 42% seen in EGFR positive. And one more important subset of liver mets where the progression is very aggressive, and patient with this is subset is very poorly behave with the chemo and other all things. But if we use this standard arm, then of B arm, then there is median overall survival 8.2 months compared to 5.1. So this also approve the effectiveness of atezolizumab in this liver metastasis also. And when we see the overall response, and also again the benefit favor the atezolizumab arm compared to without atezolizumab. So if we add bevacizumab to atezolizumab, the overall response again is 60% increased with liver metastasis compared to 41%, and patient with bulky disease, subset of bulky disease where the patient has high tumor burden, like more than third quintile, having a tumor size of 10.8 centimeter, or have more than two sites of metastasis. Again, this adding the atezolizumab arm increases the overall survival in high tumor burden 15.5% compared to 10%, and in low also seen benefit is seen in low tumor burden 20 median overall 20.3 compared to 7.1. If you look at the metastasis site, again the benefit remain the same and have very good response to the high tumor burden patients. So coming to the toxicity profile, this is a well balanced. This is again, we know we are using 4 chemotherapy, 4 drugs in this patient in this IM50 trial and B arm. So the toxicity is little bit more expected, and the main toxicity is like immune related effects, and arms like rash, hepatitis, hypothyroidism. This is more increased in atezolizumab arm. So concluding my this 1.5 trial, this is very good trial, and I've shown the effect of irrespective of PDL1. I've shown the improvement in overall survival and overall response rate when we use this atezolizumab with standard of care, and also toxicity is well matched. And the main effect we have seen in liver mets and also in EGFR positive well treated before. IM power is now next is IM Power steroid sparing study. I will just conclude in 1 minute. Give me 1 minute more. And this is in one non-commercial where the patient cannot tolerate the steroid or we cannot use steroid because of hypertension, diabetic, or any kind of contraindication steroid. Then we use this. We can take the benefit of this 130 arm where they have used this napacli, carboplatin arm alone or versus napacli carbo plus adalimumab, and this is well randomized trial, and they have randomized 2:1 ratio, and have also shown the very good response in this patient, and very good response in the patient in terms of progression-free survival of at 6 months 56.1% compared to 29, and almost 3 times response rate in the 2 time response rate at 12 month in the progressive survival in favoring the adalimumab arm when we add this in napacli plus carboplatin arm, and overall response is also seen 63% compared to 56%, and at 2 year 39 compared to 30% patients. So also overall benefit also seen across all the subgroup analysis. What we have decided for this trial, they have tried it, and also they have decided. So if we see at overall response and duration of overall response, then again adding adalimumab has improved the overall response rate of 49% compared to 31%, and also time to duration of response is higher in 46% compared to 30% patients. So again, coming to the toxicity profile, it is well matched, and again immune related effects are more compared to non-immune related, and they are well tolerated, and grade 3, grade 4 adverse event are very less. Thank you very much for patience here.
Thank you, sir. Thank you, Dr. Sandeep. Sir, it was a concise lecture on all the trials comprising of this atezolizumab. So I think, sir, we routinely don't do any PDL1 testing when we are planning for a patient on atezolizumab in our day-to-day practice. So we can directly start with the ABCP. And the thing is only the financial toxicity to the patient, because food drug combination with some of the side effects with the chemotherapy and with the immunotherapy, that becomes one of the limiting. I have not used in any of my patients till now. So maybe some of the inputs from your side, or when we have some data from the real world data, maybe that can give a better information that when we are using these drugs. So your inputs to this, sir?
So definitely, because 2-3 points are there, we can use IM power if the patient are have non-driver mutation positivity. One thing. Second thing, financial toxicity again an issue. But in our setup, just government is going to provide all things free to the patient. So we can select the patient. We are going to select these patients, subset of patients who will be really going to be benefited with these drugs. So that is the issue. Otherwise, we can go straightly for this standard with the irrespective of PDL1 status.
Yes. And sir, again, 3 cheers for you. You are organizing another mega event in the next month. So really appreciate
I just congratulate for this very good event, and I want to invite all of you for our upcoming conference in November, and it's going to be on lung, breast, and head and neck cancer patient, and on 18, 19, and 20 of November. I would love to host all of you at Jaipur.
Thank you, sir. Thank you so much for your kind invitation, sir. Thank you so much, sir, and all the best for your this conference.
Thank you, Jagdeep.
Thank you, sir. I can see Dr. Pranshu on the screen. Nice meeting, Dr. Pranshu. I have seen you.
Good evening, sir.
Very good evening. I've seen you in most of the online session only, not met till now with you physically. And I mean, physical meeting is not there. Hope to see you soon. And the next topic is basically on the durvalumab in the small cell lung cancer extensive disease. So now over to you. Dr. Pranshu he's a medical oncologist at Shelby Hospital. So over to you, Dr. Pranshu.
Thank you, sir, and I'd like to thank the organizers for giving me this opportunity. So I think we are running behind schedule, so I'll try to keep it very short. So my talk today is regarding the evolving role of immunotherapy in extensive stage small cell lung cancer. So are my slides moving?
Yes,
Yeah.
yes,
Okay.
Priyansh,
Thank
please
you.
move.
Thank you. Thank you. So we all know that lung cancer is the leading cause of cancer-related deaths worldwide. Small cell lung cancer represents around 15% of all lung cancer cases. In India, it is probably around 16%. And we all know that brain metastasis is a really challenging part for aspect of this cancer. Around 50% of the patient have brain metastasis. The median age is around 70 years. This is the data from Western. We have probably a little younger patients, and almost all patients are smokers. Up to 97% of the patient have a history of smoking. 2 in 3 patients with small cell lung cancer have an extensive stage at diagnosis, and patients with extensive stage small cell lung cancer have a very poor prognosis when taking chemotherapy alone. Which was the current standard of care till around 4 years back. The survival rate, 3-year survival rate with chemotherapy alone is less than 6%, and at 5 years it's a very dismal 1 to 3%. So if we look at the history of treatment for small cell lung cancer, the first approval of cisplatin and etoposide combination came in 1985. And for more than 30 years, it was the standard treatment, and till 2018, it was the standard first-line treatment. In the early 90s, then came the thoracic RT for a limited disease, small cell lung cancer, followed by IV topotecan in 1998, and substitution of cisplatin with carboplatin in 99, along with fractionated RT as well as PCI for limited stage small cell lung cancer. Topotecan oral came in 2007, and for second line therapy, we had nivolumab approval in 2018. But the real game-changing trials came in 2018, the trial of atezolizumab IM Power 133, along with the carboplatin and etoposide, and followed the next year by the Caspian trial of carboplatin etoposide or cisplatin etoposide plus durvalumab. Since cisplatin and etoposide was established as a standard of care in 1985, more than 30 years ago, there was little change in the management of extensive stage small cell lung cancer in the first line. This chemotherapy was compared with a lot of other regimens, but none of them showed any superiority over this regimen as in the aspect of survival outcomes or toxicity profile. So in the late 2018 and 19, we had the immunotherapies which have shown a promising newer standard of care for extensive stage small cell lung cancer. So this is what we used to do before immunotherapy came into being, or in a lot of patients still now who cannot afford immunotherapy. The standard chemotherapy regimen of a platinum doublet, platinum plus etoposide chemotherapy for 4 to 6 cycles with PCI and radiotherapy at physician's discretion, followed by observation and just waiting for relapse, because most of the patient would eventually relapse. And then platinum re-challenge if it is a platinum sensitive disease. Some studies actually shown that instead of 6 months, we usually take a 3 months cutoff, because it's a very aggressive disease. And if it's platinum refractory, then we have the option of topotecan, lurbinectedin, or a clinical trial. And if no treatment is possible, then best supportive care is the treatment of choice. So now we have first line immunotherapy combinations. Both atezolizumab as well as durvalumab are approved in first line, both by FDA and NCCN as well as ESMO. So along with durvalumab, you can use carboplatin or cisplatin plus etoposide for 4 to 6 cycles, followed by a maintenance immunotherapy. And at relapse, you can re-challenge with the platinum if it's platinum sensitive, or for refractory disease, you can have the treatment options we've already mentioned. PCI and radiotherapy is at the physician's discretion. So if we use chemotherapy alone, the overall response rate is usually 60 to 70%. Usually patients respond well in the first line, but that response is usually short-lived, and a median PFS is around 5.5 months with chemotherapy alone. And the median OS is usually around 7 to 12 months, and a 1-year OS is a dismal 40%. So based on this background, neo treatment options were needed to improve duration of response and overall survival for patients with extensive stage small cell lung cancer. Another important aspect is that as the lines of therapy increase, the patient eligible for chemotherapy decreases substantially. In the first line, around 80 to 100% of the patients might be eligible for therapy, but it decreases to 30 to 50% in the second line and less than 20% in the third line. So we have to use the best option first. So demonstrating a sustained benefit in the first line setting is paramount to improve patient outcomes in this disease. When we talk about the atezolizumab trial, the IM-Power 133, the response rates were 60.2%, and the median PFS was a little over 5 months, 5.2 months. And but the issue was that although 2-year survival was 22%, but we did not have a further data for overall survival. And if you see, the curves are trending towards convergence, and long-term survival more than 2 years is still uncertain. We all know that 2 in 3 patients with small cell lung cancer have an extensive stage disease at diagnosis. And despite improving outcome, treatment with atezolizumab can only be used in combination with the topoisomerase plus carboplatin, and survival data more than 2 years is currently lacking. The 2-year survival data is around 22%. So then, we have the Caspian trial, published in 2019 Lancet. And this is a study designed for Caspian, a newly diagnosed extensive stage small cell lung cancer. 805 patients were included in this trial with a ECOG PS of 0 to 1, although in practical aspects we have a very less patient in the subgroup, but that's how the trial was designed. The life expectancy of at least 12 weeks, and a patient having at least 1 target lesions measured by RECIST 1.1. And the stratification was based on the type of chemotherapy, as a cisplatin or carboplatin. So they were randomized 1:1:1 into 3 groups. There was a durvalumab plus chemotherapy arm. The platinum choice was based on the investigator's choice. And they were given 4 cycles every 3 weekly, followed by a maintenance phase of 4 weekly durvalumab. And the control arm was again topoisomerase plus either cisplatin or carboplatin with 4 to 6 cycles, and up to 6 cycles were allowed every 3 weekly. And the third arm was durvalumab plus chemotherapy plus tremelimumab. So the primary endpoint was overall survival, and the key secondary endpoints were PFS, overall response rate, the overall survival at 18 months, the PFS at 6 and 12 months, and health-related quality of life. So this trial allowed for investigators' choice of platinum-based chemotherapy, and patients with asymptomatic or treated brain metastasis were allowed. So these are very important points. This is how the common practice guidelines also suggest, and this is how we treat patients daily. The control arm also allowed up to 6 cycles of chemotherapy and PCI as per investigator's discretion. So these are very salient points which differentiate this trial design from that of the atezolizumab. So Caspian reflected international clinical guidelines, which were more closely aligns with how patients are treated in the real world. So the guidelines suggest that both carboplatin and cisplatin can be used. Use is left up to physician's discretion. So this was the case in the Caspian trial, but in the IM-Power 133, only carboplatin was allowed. Coming to brain metastasis, treatment for patients with symptomatic and asymptomatic brain metastasis with radiotherapy is recommended before or after systemic therapy, respectively. Similar was the design with Caspian trial, but in patient with IM-Power 133, patients with brain metastasis were only eligible if they had received prior treatment. Also, international guidelines recommend between 4 to 6 cycles of chemotherapy, but in IM-Power 133, only 4 cycles were allowed. While in the Caspian trial, the control arm allowed up to 6 cycles of chemotherapy. Now coming to the 3-year overall survival data in the Caspian trial, The median OS was 12.9 months in the combination arm versus 10.5 months in the chemotherapy alone arm, with a hazard ratio of 0.71. And if you look at the landmark 3-year analysis, the patient in the durvalumab arm had an improved overall survival, 17.6 months versus 5.8 months in the control arm. And very importantly, there's a clear separation of the curves, which is sustained, and with a notable flattening of the curve observed after 27 months onward, which further support a sustained long-term overall survival benefit. So in future, we might have an impressive 5-year overall survival data with durvalumab. So durvalumab is the first and only IO drug to show a sustained long-term survival benefit of up to 3 years. If we compare the two trials, the median OS is almost similar, 12.3 months in the IM Power 183 versus 12.9 months in Caspian trial. Hazard ratio also quite similar, 0.76 and 0.71 respectively. But if we look at the 3-year overall survival data, that is lacking in with atezolizumab, while it is an impressive 17.6% in the durvalumab trial. So is the 2-year overall survival good enough to make the treatment choice for sustained and durable response with IO drugs? So this is the question which would definitely be coming in our mind when we prescribe an IO drug in combination with chemotherapy in this disease. So at 3-year overall survival, 17.6% in durvalumab, atezolizumab, we don't have the data yet. Now coming to the subgroup analysis, so durvalumab plus chemotherapy was evaluated in key patient subgroups reflective of clinical practice in extensive stage small cell lung cancer. So patient who was cisplatin and carboplatin eligible, patients over the age of 65, both former and active smokers, and patient with brain or CNS metastasis. So as we can look that almost all subgroups derived benefit with this combination of durvalumab plus chemotherapy. Again, it is, if we come to the overall response rate analysis, the response rates were 10%, almost 10% more in the durvalumab arm, almost 68% versus 58% at the 2-year interval. And also the duration of response was, significantly prolonged. The 24-hour duration of response analysis showed that the median duration of response was almost similar, but the patient who were in response at the end of 2 years was almost 3 times in the combination arm versus control arm, 13.5% in the durvalumab arm compared to 3.9% in the chemotherapy alone arm. So again, if we see the 24 months progression-free survival, it was an impressive 11% in the durvalumab arm compared to just 2.9% in the chemotherapy arm. So at 2 years also, almost a ninth of the patient were having would not have been progressed in the durvalumab arm. So almost 3 times the number of patients were progression-free at 12 months, and nearly 4 times the number of patients were progression-free at 24 months with durvalumab plus chemotherapy versus chemotherapy alone. 9.1% of the patients have been on durvalumab for more than 3 years, and 10.1% of the patients were continuing treatment with durvalumab at the 3-year data cut off. So that is an impressive figure in a disease which has been, historically very dismal prognostic. So again, the overall survival based on whether there were brain metastases or not at the baseline. So durvalumab plus chemotherapy consistently improved overall survival regardless of the presence of baseline brain metastasis. So it had a hazard ratio of 0.69 in patient with brain metastasis as well as 0.74 in patient who did not have brain metastasis. Again, the overall survival 12 months versus 8.8 in patient with brain metastasis and 13 months versus 10.5 months in patient without brain metastasis. Now coming to the safety profile at 24 months, if we see the rate of grade 3 and 4 adverse events and serious adverse events were numerically lower in the durvalumab arm compared to the chemotherapy arm. And the discontinuation rates were also similar. There was a nominal difference in either arm. The immune-related adverse events were higher with durvalumab compared to chemotherapy, but they were driven by thyroid events, and the majority of the immune-related events were low-grade and managed in line with the standard treatment guideline. So, the treatment discontinuation rates were also similar in both these arms. When the safety profile was analyzed at 36 months, again, the rate of grade 3 adverse events and serious adverse events were numerically lower in the durvalumab arm compared to chemotherapy. And the safety and tolerability for each combination in the trial was consistent with the known safety profiles of these agents. 9.1% of the patients have been on durvalumab for more than 3 years, and 10.1% of the patients were ongoing treatment with durvalumab at the 3-year data cutoff. Now coming to the quality of life, in almost all the parameters, whether it's global health status, cognitive functioning, emotional functioning, physical functioning, role functioning, or social functioning, durvalumab combination was better or at least as equal to chemotherapy arm. Now coming to the time to symptom deterioration from baseline, it was also better. It was also, in these two indicators, that is URTC C30 and LC13, if we see both these quality of life indicators showed that the combination of durvalumab plus chemotherapy favored, better outcomes with respect to these symptoms like appetite loss, constipation, diarrhea, dyspnea, fatigue, nausea, vomiting, pain, insomnia, cough, dyspnea, hemoptysis, or pain. Then coming to the maintenance, the dose used in induction and maintenance. So Caspian administration schedule was the fixed dose of durvalumab 1500 milligram along with etoposide and carboplatin every 3 weekly for 4 cycles, followed by maintenance until disease progression or an unacceptable toxicity. Again, the dose was a fixed 1500 milligram, but we have a 4 weekly maintenance dose, which is more convenient in this setting. Now coming to the chief differentiating factors in the two study designs of IM Power 133 and the Caspian trial, if we look the main differences were the first was the brain metastasis. Untreated brain metastases were excluded in the IM Power trial, while in Caspian they were included. PCI was also at the physician discretion in the Caspian trial. Again, it was up to 6 cycles of chemotherapy were allowed in the Caspian trial in the control arm, while this was not the case in IM Power. Cisplatin was excluded in IM Power 133 but included in Caspian trial. So we may have some minority of patients who might have hypersensitivity with carboplatin or any other reason for discontinuation. Then for that, durvalumab would be better compared to atezolizumab. So this we have discussed. So these are the guidelines. The NCCN guideline have a category 1 indication for durvalumab in combination with both carboplatin as well as cisplatin for 4 cycles, followed by maintenance of 1500 milligram every 28 days. So to conclude, the first line durvalumab plus etoposide platinum has shown sustained improvement in overall survival compared with a robust control arm that is reflective of a real world scenario by allowing up to 6 cycles of chemotherapy and the use of PCI as compared to the results of the atezolizumab plus carboplatin etoposide study of IM Power 133. Durvalumab is the only IO that provides flexibility of choosing cisplatin carboplatin along with etoposide. The benefit with durvalumab plus etoposide platinum was observed across all subgroups, including brain metastasis subgroup. More than 17% patients on the durvalumab arm are surviving even after 3 years, showing prolonged survival benefit. Durvalumab plus chemotherapy provided a high response rate and demonstrated ongoing responses at 2 years and 3 times more patient than the chemotherapy alone arm. Durvalumab offers convenient once monthly dosing regimen in the maintenance phase, and the safety findings remain consistent with the known safety profile of durvalumab and the platinum etoposide combination. So thank you, and over to the organizers.
Thank you, Pranshu. This was a quite important topic. We see a lot of patients with extensive stage small cell lung cancer, and they usually are in the either ECOG PS2 or 3. And we cannot, in our setup, we don't leave the patient, we have to treat. But honestly, I have not any patient who can say who has not responded. Usually the patient respond very less, and more than 40% patient, they have the upfront brain metastasis when that time of presentation. So this durvalumab was a breakthrough in the treatment of the patient, and the good thing is that up to 3 years, the data is available with us, And it is exactly the real world picture. Means the patient who are already having the brain metastasis got treatment at some institutes, then they visit to your clinic, and then you have to plan some treatment regarding. Sometimes they have not received any systemic therapy, but they have only received either whole brain RT, or they might not be have received any treatment. So this includes the real picture of the patient which we see in our day-to-day practice.
Yes.
Thank you, Pranshu. Thank you
Thank
so
you,
much.
sir.
Thank you so much. So next session is with Suvir. Suvir, are you there?
Yes, yes.
So Suvir is another personality with us. He's my colleague, hematologist. And one important topic which is usually not discussed in the things is regarding the romiplasty and chemotherapy-induced thrombocytopenia. Over to you, Suvir.
Thank you, Dr. Chikdeep. So looks like a very active conference. So my slides are visible, is it?
Visible. It is active, but you became active right now. I was searching for your activity initially.
So basically, so chemotherapy-induced thrombocytopenia is is kind of a new thing which we are hearing nowadays. So I just thought we'll just look at what is the evidence which is existing right now for this problem. So it is basically defined as when you have platelet count of less than 1 lakh in a patient who's receiving myelosuppressive chemotherapy. And this is an important definition because patients who are getting myeloablative chemo like for AML or for transplant, so they don't fit into this definition. And it's a common problem because ranging from 20 to 60% of patients in some study, in a large study actually of over 40,000 patients were found to have chemotherapy-induced thrombocytopenia. Now, the problem with that is we can give transfusions, but they are only short lasting, only for a few hours. And the problems such as reactions, infections, aluminization, refractoriness. And there's a significant cost related to the care also, which is almost $2,000 more than normal chemo cycles. We had IL-11 agonists which are available, but there's no sustained benefit which has been noted so far. Now, this can actually lead to reduction in the dose intensity, or we can choose less effective regimens, or treatment may even be stopped in some settings. But most of these are problems which are noted with solid cancers. And it's important to look at a few concepts related to this. One is that platelet count is not an accurate predictor of bleeding risk. If you look at this graph, the days without bleeding go up significantly. Uh, uh, so the other way to say this is the bleeding risk goes up significantly once your platelet counts go below 10,000. So if you see this line is almost similar from 10,000 to 1 lakh, and only less than 10,000 you start seeing an increase in the bleeding risk. The other problem is that bleeding may be due to functional problems. So drugs such as antipyretics, anti-inflammatory drugs, renal failure, they can cause bleeding in the presence of a normal platelet count. And when you have chemotherapy-induced thrombocytopenia, the patient here behaves like a patient with aplastic or AML or MDS, in which the platelet is not being produced. Compared to this, in patients with ITP, the platelets are being produced at a higher rate, and you have larger platelets, so the bleeding risk is not very high. So for each patient, the bleeding risk is unique and it needs to be personalized before we start thinking of starting any treatment. Other than chemotherapy, we should also look for other causes of thrombocytopenia, such as is it because of disease, if there's any metastasis or marrow infiltration, whether you have associated ITP, which is especially seen in low-grade lymphomas, especially CLL, and whether any infection is there, dengue or disseminated TB, any other drug is causing the thrombocytopenia, and any coagulopathy, such as gastric or pancreatic adenocarcinomas, can lead to DIC. And then you can also thrombotic angiopathy related to mitomycin C and gemcitabine. So all these have to be thought of when we start to see a patient with unexplained or prolonged thrombocytopenia. So this is just a summary of what I have told. You can have problem with the count, problem with the platelet function, problem related to what intervention or drugs that we're giving to the patient. These are causing the problems. Now the main thing here is that there is a thrombopoietin feedback mechanism which we have, in which the thrombopoietin is produced by the liver, and this goes and binds to megakaryocytes in the bone marrow. And when the platelet production is high, this gives a feedback signal to stop the production of thrombopoietin, and the production goes down. So because of this complex mechanism, CIT can happen actually because of multiple mechanisms rather than just suppression. So you can have decrease in the stem cells which produce megakaryocytes. You can have drugs which only affect the mature megakaryocytes or later progenitors. And there are drugs which lead to abnormal megakaryocyte function by inhibiting platelet shedding. You can also have situations in which platelet destruction is increased, such as in immune thrombocytopenia, thrombocytopenia or thrombotic myopathy, which I just talked about. And drugs like venetoclax and cisplatin have been shown to cause platelet apoptosis, which will reduce the platelet count. There are some other drugs, especially the kinase inhibitors, which can reduce the platelet function. Now, romiplastim is a very important part of treatment for ITP. But in CIT, what happens that TPO is usually produced by the liver at a constant rate, and it has no storage form. So essentially speaking, the TPO production goes down with the increasing platelet count. So as the platelet starts to fall, the TPO level usually goes up because it is produced by the liver, and this will try to stimulate the production of platelets. So the therapeutic role here is that because TPO production is a normal mechanism, we can try to supplement it by giving TPO receptor agonists, which can increase the platelet counts. So we have two main molecules available for clinical use. One is eltropag, other is romiplastim. So they are similar to each other, but the structure and mechanism is different. Both of them act on the thrombopoietin receptor and lead to downstream activation of signaling. Romiplastim acts on the extracellular part and eltropag on the intracellular transmembrane part of the receptor. Practically speaking, so eltropag is oral, romiplastim is parenteral. And the main thing is that Ultramopac requires a lot of dose modification, especially in East Asian patients, liver dysfunction, and it has some drug interaction as well compared to romiplastim, which doesn't have similar interactions. And apart from ITP, liver disease, and MDS, now these three in red are the most strongest indication for TPO receptor agonist. Other ones, I would say they are upcoming indications, and there is data which is emerging in those areas. So this just to see, we should look at the first three columns. This is recombinant human TPO. This is a molecule which was initially introduced in 1990s and 2000. This is not available all over the world, but Chinese people are using it quite commonly. It's a very potent activator of the thrombopoietin receptor. And if you look at romiplastim and eltrombopag, there's a marked difference in the potency. So most of the studies in CIT have looked at romiplastim because of a higher potency and a faster response in the platelet count. Now we know that most of them will act on the platelet count, but the main doubt is whether it will have any effect on maintaining the chemotherapy dose, whether it will reduce your bleeding or transfusions, and whether it will have any effect on survival. And the most important thing is that the CMPL, this is a thrombopoietin receptor. This is not present on any solid tumors. So there is no theoretical risk that these drugs are going to stimulate these tumors to cause resistance or cause progression. So these are few studies which have led us to today. So in the year 2000, so this was an initial study which showed that with recombinant human TPO, this was not romiplastim, it's a recombinant thrombopoietin. When you use it with chemotherapy, the nadir of the platelet count is lesser and the time to recovery of platelet count is faster. So time you spend in a platelet count of less than 20 or 50,000 is much lesser. The need for transfusion is reduced and the time to recovery for more than 1 lakh is faster once you use thrombopoietin recombinant with the chemotherapy. And this is one of the important trials, and this is typically the design of most of the trials which have looked at this area. Patients whose counts fall to less than 1 lakh for at least 4 weeks. Some have used a time period of 3 weeks, but 3 to 4 weeks, despite dose reduction or delay of chemotherapy, usually fall into the inclusion criteria for most of the trials. So if you look at this trial published in JCO in 2016, so what they looked at was when they enrolled the patients, mean platelet count was about 60,000. And patients who got romiplastim, this is the blue line here, the recovery of counts was much faster, and the time spent in a count less than 1 lakh was much lesser compared to those who had a placebo. And it's important to know that patients who were having solid tumors, more than 70% had a response, and more than 89% avoided any platelet transfusions. And if you look at the blue line here, this is the patients who had solid tumors. But if you look at this gray line, this is solid tumors who did not have a response, and the purple and red lines are patients with lymphoma and myeloma. So this is especially what we talked about. Patients with hematologic cancers involving the marrow, they will typically not have a response, similar to patients with solid tumors who won't respond. And solid tumor patients who have marrow involvement in the tumor, who have received pelvic radiotherapy, or have received treatment with temozolomide are known to not respond to romiplastim also. Now, the various regimens which have been tested, you can either use a weekly regimen, which is a fixed dose of romiplastim, which comes irrespective of the chemo dosage. And the second is an intra-cycle regimen, in which between the 2 cycles, you fix a time and you give the dosing as planned. And this is only a single study comparing that. But if you see the dark blue line, that is the weekly regimen. And as expected, that has a higher median platelet count that is maintained. And the patients who get an intra-cycle dosage usually have a lesser platelet count. Now, this is just to show the data which is available in this area. The first column will show that these are all retrospective cohort phase 2 kind of studies. There are no randomized controlled trials in this area. And all of them are single center, small patient number studies. Most of them have shown some improvement in the platelet count compared to placebo, and most of them are compared to placebo and not against some other standard of care. And but what is the effect on survival or preventing chemotherapy dose delays is uncertain. This is again a meta-analysis in June 2022. If you look at romiplostim, there are a total of 7 studies so far, 2 RCTs, and remaining are all small studies which have not compared head to head. So even in this, the conclusion was that there was no significant effect actually on dose delays or reduction in the meta-analysis on severe thrombocytopenia transfusions or risk of bleeding. But what was noted was individual studies definitely had some benefit by using romiplostim. So they concluded by saying that these may actually improve outcomes in secondary prevention. So somebody who's had a thrombocytopenia in the first cycle, you might be able to use it as a secondary preventive measure. But the main thing is it needs an RCT to give us a conclusive answer to that. So take home message here is that chemotherapy-induced thrombocytopenia is definitely a significant problem, and this is mostly in the area of solid tumors, not in hematologic cancers, and patients who are receiving myeloablative or AML kind of chemotherapy. And most studies here are phase 1 or phase 2 studies. Phase 2 studies, there are phase 3, there are 2 studies which have not shown any benefit of using this. But definitely, whatever evidence is there, we can use it for patients in which whom chemotherapy is getting recurrently delayed. We should always discuss the level of evidence with the patient. And there is a 5 to 10% risk of VT as seen in the previous studies. In patients in whom the platelet count falls to less than 1 lakh for more than 3 to 4 weeks, which delays chemo, this definitely is something which can be considered. And it is important that in patients of high risk MDS and AML, we should be careful as theoretically these are known to stimulate blast production and should not be used routinely in this setting. So that was a short summary of this data. Over to you, Dr. Jagdeep.
Thank you, Dr. Sweet. You just pointed out that though the studies are very small, can we use it as a you just have said that secondary can be given prophylactic? Any primary prophylactic? Any studies like that, or some retrospect studies, or any
So
some cases?
primary, no. So I'm not aware of small series. So most of the bigger trials have actually looked at patients who already had a problem with the first or second cycle. So patients who had recurrent delays in the chemotherapy or platelet count didn't go above 1 lakh for more than 3 to 4 weeks were included. Now I don't know which chemo cycles get delayed by that level of platelet count. They've kept a cutoff of 60,000. So I think that will depend on patient to patient and the cutoff which we keep for each chemotherapy. So like for us for high dose methotrexate it is 60,000, hypersevere it is 60,000. So like that depending on the chemo and the disease it may be variable.
So other important thing which I want to ask, like you just told that it is more better to give in patient with a solid cancer rather than with the EML or MDS. So it means the patient who are receiving either gemcitabine-based chemotherapy or carboplatin-based chemotherapy, in which we anticipate that they are going to have a more of like platelet dysfunction or decrease in the platelet or some bleeding disorders. So can it be used along with the chemotherapy at the same point, or some timeline of dosing schedule, something different with that?
So that's what. So there are there's only one study which has looked at it, and they have said that when you give it weekly routinely, so don't think about the schedule, just keep giving it weekly, and then titrate it according to the platelet count. So that has shown a higher platelet count and less variability compared to
Not
once you
like
give intracycle.
what we think with the filgrastim, we don't give on the day when the chemotherapy is there. So it
No,
has
no.
no
So
danger.
romiplostim, correct. So romiplostim, that study, that is why the level of evidence is not uniform because I don't think it will be easy for us to have a single answer to this because the chemotherapy is different, the intensity of chemotherapy, disease, everything is different. So the studies are looked at all solid tumors within the same study, within the same trial. So so that way they have tried to give it weekly as a regular dose, just like ITP, and that has shown a slightly higher response rate.
Thank you, Suvir. Thank you so much.
Thank you.
So, so by this we conclude our sessions, and thanks all for your patience listening, and thank you Tarun and associates for organizing all this event along with and making the things simpler for me. Thank you, Pooja.
Thank you, sir.
Thank you,
Thank
Ekta.
you.
Thank you.
Thank you, everyone, for joining. Good night, everyone. Thank you,
Thank you.
Pooja.